Hello, everybody, and welcome back to MooseMed. I hope you guys had a good summer. I know I did. I got engaged, and I got myself a little kitty named Otter. You may hear her in the background here and there throughout the video. I don't know. I hope I have a good enough microphone, but she's around. So yeah, I don't know. I'm happy to get going. So this is Foundations 2, Week 1 and Week 2. We're going to be covering mainly a lot of pharmacology, a lot of boring stuff around pharmacology, but it gets pretty fun with the drugs. And then we'll do a little soft intro for pediatrics. And then we also have a brief genetics review as well. So with this video, really just make use of it as you do with the other videos. Skip around to whatever you need. Honestly, if you're comfortable with a lot of the groundwork with this content, I would just skip straight to when I start talking about the drugs because I have a lot of fun ways to try to remember them. With that said, let's get cooking. It's good to be back. Foundations 2, here we go. Okay, so before discussing specific drugs, we need to distinguish pharmacokinetics from pharmacodynamics. Pharmacokinetics describes what the body does to a drug. This includes absorption, distribution, metabolism, and elimination, often remembered as just ADME. Okay, so then we got pharmacodynamics, and this describes what the drug does to the body. So they're just inverses of each other. So with pharmacodynamics, this would be something such as activating or blocking a receptor to produce an effect. A drug is administered, absorbed, and distributed to its target. It then produces a pharmacodynamic response before redistribution, metabolism, and excretion reduce its concentration or remove it from the body. So in short, pharmacokinetics determines how much drug reaches the target and for how long, while pharmacodynamics determines what happens once it gets there. So the route of administration affects how quickly a drug reaches the circulation, its bioavailability, and whether it undergoes first-pass metabolism. Enteral routes include oral, rectal, and sublingual administration. Oral drugs are convenient but may be incompletely absorbed and often pass through the liver before reaching systemic circulation. Sublingual drugs are absorbed through the oral mucosa and largely avoid what's called first-pass metabolism. We'll get into it a little bit later. Parenteral routes use injection, including intravenous, intramuscular, subcutaneous, and intradermal administration. Intravenous administration provides immediate and complete systemic availability. Drugs can also be delivered through local or specialized routes, such as topical, transdermal, inhaled, nasal, vaginal, or ophthalmic administration. The formulations, such as tablet, solution, suspension, or ointment, also influences the drug's absorption and clinical use. So most drugs produce their effects by interacting with receptors. These interactions are usually reversible and involve several non-covalent forces, including ionic interactions, hydrogen bonding, hydrophobic forces, and what's called van der Waals forces. Covalent binding is less common and is generally irreversible. Only the free, unbound fraction of a drug can usually leave the circulation, reach tissues, and bind receptors. Drug attached to what's called a plasma protein acts as a temporarily unavailable reservoir. So several terms describe drug action. Potency tells us how much drug is needed to produce a particular effect. Efficacy is the maximum response that a drug can produce, and the margin of safety compares effective and toxic doses, while the therapeutic index is commonly expressed as the toxic dose divided by the effective dose, so it's a ratio. A larger therapeutic index generally indicates a wider safety window. A drug's effect can end even before the drug has completely left the body. One mechanism is redistribution. Blood flow carries the drug away from the site of action and into other tissues, reducing its concentration at that target. This is especially important for highly lipid-soluble drugs that rapidly enter the brain and then redistribute into muscles and adipose tissue. The second mechanism is metabolism or biotransformation, and this occurs primarily in the liver, although the kidney, lungs, gastrointestinal tract, skin, blood, and other tissues may contribute to this. The third mechanism is excretion. The kidneys are the major route here, but drugs may also leave through bile and feces, the lungs, sweat, saliva, and other secretions. Redistribution removes a drug from its target, whereas metabolism chemically changes it, and then excretion finally removes it from the body. Drug metabolism generally makes lipid-soluble compounds more polar and easier to eliminate. It may inactivate a drug, activate a prodrug, or occasionally produce an active or toxic metabolite. Phase 1 reactions include oxidation, reduction, and hydrolysis. These reactions expose or introduce a functional group and often involve the cytochrome P450 enzyme system. Phase 1 usually increases polarity, and the resulting metabolite may be active, inactive, or toxic. Phase 2 reactions attach a polar molecule to the drug through what's called conjugation. Examples include glucuronidation, sulfation, and acetylation. Sorry guys, coming off of summer, I'm brushing off the pronunciation. These products are generally highly water soluble and usually are inactive. Not every drug must pass through both phases, and some enter phase 2 directly. Levodopa is an example of a prodrug. It crosses the blood-brain barrier in an inactive form, and then it's converted into active dopamine within the brain. So drug elimination occurs primarily through the kidneys and through the liver and bile. Renal elimination involves 3 major processes. First, during glomerular filtration, small free drug molecules enter the filtrate. Drugs bound to plasma proteins are not readily filtered. Second, active secretion transports certain drugs from the blood into the proximal tubule. Separate transport systems handle many organic acids and organic bases, and drugs may compete for these transporters. Third, passive reabsorption can return drugs from the renal tubule to the blood. So lipid-soluble, non-ionized drugs cross membranes more easily and are therefore more likely to be reabsorbed. Ionized water-soluble drugs tend to remain trapped in the tubular fluid and are excreted in the urine. The major takeaway is that metabolism usually makes drugs more polar, allowing the kidneys to eliminate them more effectively. All right, so an agonist binds to a receptor and changes its activity. A full agonist can produce the receptor system's maximal response. A partial agonist activates the receptor but produces a lower maximum response, even when all receptors are occupied. An inverse agonist binds the same receptor but decreases its baseline activity. An antagonist binds without activating the receptor and prevents an agonist from producing its effect. A competitive antagonist competes with the agonist at the same binding site. Its effects can often be overcome by increasing the agonist concentration. A non-competitive antagonist reduces the response in a way that generally cannot be fully overcome by adding more agonist. Allosteric modulators bind at a different receptor site, and they alter receptor behavior and may either enhance or inhibit the agonist's action. These terms all contain 50, but they measure different things. The dissociation constant, or KD, is the drug's concentration at which 50% of receptors are occupied. A lower KD indicates greater receptor affinity because less drug is needed to achieve that level of binding. EC50 is the concentration that produces 50% of the drug's maximal effect. It is used when graded dose-response relationships and helps describe potency. ED50 is the dose that produces a defined therapeutic effect in 50% of a population. TD50 produces a specified toxic effect in 50% of the population, while LD50 causes death in 50% of test animals. The therapeutic index is commonly calculated as TD50 divided by ED50. A higher value generally represents a wider separation between therapeutic and toxic doses, which is what we want. Binding and effect are related, but they're not identical. A binding curve plots receptor occupancy against drug concentration. As the concentration rises, occupancy increases until the available receptor becomes saturated. KD is the concentration at which 50% of the drug receptors are occupied. So a drug with lower KD has a higher affinity and appears farther to the left on this binding curve. A graded dose-response curve instead plots the magnitude of a biological effect against concentration. So EC50 is the concentration that produces 50% of the maximal response and is a measure of potency. Emax is the greatest effect the drug can produce and reflects efficacy. KD does not necessarily equal EC50. Because of signal amplification in spare receptors, a drug may produce a large effect without occupying every receptor. Dose and concentration describe related but different measurements. So dose is the amount of a drug administered to a patient, whereas concentration is the amount of drug present in a particular volume or at its receptor. So the same dose can produce different concentrations depending on absorption, distribution, metabolism, and elimination. Potency answers the question, how much drug is needed? It is commonly described as using EC50 or ED50. A lower EC50 or ED50, and therefore a curve shifted to the left, indicates a greater potency. Efficacy answers how large an effect can the drug produce. It is represented by Emax, or the height of the curve's plateau. A higher plateau means a greater efficacy. Clinically, efficacy is often more important than potency because potency mainly determines the required dose, whereas efficacy determines the greatest response that can be achieved with said drug. All right, so again, a partial agonist binds to the same receptor as a full agonist but has a lower intrinsic efficacy. So when given alone, it activates that receptor, but its response is weaker. But even a full receptor occupancy, it never reaches the same Emax as a full agonist. Its behavior changes when a full agonist is actually present. So because the two drugs are competing for the same receptors, the partial agonist starts to displace some of the full agonist. So in the long run, it actually produces a weaker response at those same receptors, decreasing the overall effect. In this setting, the partial agonist functions like a competitive antagonist because of that. An inverse agonist is different. It reduces constitutive or baseline receptor activity. A neutral antagonist just flat out blocks agonists and inverse agonists without changing baseline activity itself. So it's just a straight out break, right? But that inverse agonist is exactly what it sounds like. It's the inverse. So you're going to see an inverse of what a normal agonist would do. All right, so non-competitive antagonists reduce the response to an agonist through mechanisms that cannot be fully overcome by increasing the agonist concentration. One mechanism is irreversible binding at the agonist binding site, often through a covalent bond. This permanently removes the receptors from available receptor pool until the cell produces new ones. So some antagonists are considered pseudo-irreversible because they dissociate so slowly that their effects are functionally prolonged. The second mechanism is binding to an allosteric site. So this changes receptor function without directly competing for the agonist binding site. The characteristic dose response finding is a reduction in the Emax or max efficacy because the system loses functional signaling capacity. EC50 may remain similar or may change depending on the receptor system and the presence of spare receptors. The key distinction is that adding more agonist cannot fully restore the original maximum response here. A quantile dose response curve measures an all or none outcome across a population. So each individual either reaches the predefined endpoint or does not. Examples include falling asleep, experiencing a specific reduction in blood pressure, developing toxicity, or just flat out dying. But the x-axis represents dose or concentration, while the y-axis shows the percentage of individuals who meet that defined endpoint. As the dose rises, progressively more individuals cross the response threshold. The bell-shaped curve shows how many new individuals respond within each dose range. So the sigmoid curve is cumulative and shows the total percentage of people who have responded by each dose. These are two presentations of the same population data. For a therapeutic endpoint, the ED50 is the dose that produces the defined response in 50% of the population. If concentration rather than dose is plotted, the corresponding midpoint may be labeled as EC50. Selectivity asks which drug effects occur at the lowest clinically relevant dose or concentration. A selective drug produces its intended effect more readily than its unwanted effects. However, selectivity is dose-dependent rather than absolute. At lower concentrations, a drug may primarily interact with its preferred target. As the concentration increases, it can begin interacting with additional receptors or pathways, producing adverse effects. On the graph, the therapeutic response curve lies to the left of the adverse effect curve. Greater separation between these curves generally means greater selectivity and a wider range in which benefit can occur without toxicity. Patients' variability is important here, right? So some patients experience adverse effects at concentrations that other patients require for a benefit. So the ED50 describes therapeutic dose, the TD50, remember, describes toxicity, and the LD50 describes the lethality in test animals. The therapeutic index and therapeutic window both describe drug safety, but they're not identical. The therapeutic index is a numerical ratio calculated as TD50 divided by ED50. A larger ratio means greater separation between doses that produce benefit and toxicity. A small therapeutic index indicates that careful dosing and monitoring may be necessary. The therapeutic window is the clinically useful range between the minimum effective concentration and the minimum toxic concentration. A wide window makes dosing more forgiving. With a narrow window, a small change in dose, drug interaction, or altered kidney or liver function may cause treatment failure or toxicity. Curve overlap also matters because population averages do not guarantee safety for every patient. The acceptable risks depend partly on the disease, right? So greater toxicity may be accepted with when treating a life-threatening condition such as cancer, right? It's all about benefits outweighing the adverse reactions. Drug receptors can be organized into 5 major signaling mechanisms. First, lipid-soluble ligands can bind intracellular receptors and alter gene transcription. These responses develop slowly but may last for hours or days. Second, some membrane receptors contain intrinsic enzyme activity. Receptor tyrosine kinases are the major example here. Third, enzyme-linked receptors lack their own enzyme activity but recruit associated enzymes, such as JAK proteins. Fourth, we have ion channels, which open or close in response to ligand binding, voltage changes, or intracellular signals. They produce the fastest response, often within milliseconds. Fifth, we have G protein-coupled receptors, which activate G proteins and second messenger pathways, and these responses are rapid and can be strongly amplified. As a general timing rule, ion channels are the fastest, followed by GPCRs, enzyme-associated pathways, and finally, intracellular receptors. Okay, so now breaking each of these down, so starting with intracellular receptors. Intracellular receptors are activated by lipid-soluble ligands that can cross the plasma membrane. Depending on the receptor, it may be located in the cytoplasm or already within the nucleus. After the ligand binds, the activated receptor commonly dimerizes and binds specific DNA sequences called hormone response elements. This changes the gene's transcription, leading to the synthesis of new proteins that produce the physiological response. Because transcription and translation takes time, the onset is relatively slow, from about 30 minutes to several hours. The effects may persist long after the ligand has been eliminated because the newly synthesized proteins remain active until they are degraded. Examples include receptors for glucocorticoids, mineralocorticoids, estrogen, progesterone, testosterone, and thyroid hormone. Thyroid hormone is kind of one to keep an eye on because even though it is technically a protein molecule, it acts like a steroid, so it's able to diffuse through that membrane. The high yield principle is slow onset but prolonged effect, okay? Receptor tyrosine kinases contain their own intracellular enzyme domain, so the receptor itself is the enzyme. Ligand binding commonly causes receptor dimerization and autophosphorylation. Signaling proteins then bind to the phosphorylated receptor and activate pathways such as the RAS-MAP kinase. These pathways regulate growth, metabolism, differentiation, and survival. Examples include receptors for insulin, EGF, PDGF, and VEGF. JAK-STAT receptors work differently. The receptor has no intrinsic kinase ability. Instead, a Janus kinase, or JAK, is attached to its intracellular surface. Ligand binding activates that JAK, which phosphorylates STAT proteins. STATs dimerize, enter the nucleus, and regulate gene transcription. Growth hormone, prolactin, erythropoietin, and interferons use this pathway. So the memory distinction is pretty simple here. So RTK has that built-in kinase, whereas JAK-STAT uses an attached kinase. Ion channels control ion movement across cell membranes and can rapidly change membrane potential or intracellular ion concentration. Ligand-gated channels open or close when a chemical messenger binds. Important examples include nicotinic acetylcholine receptors, GABA-A receptors, glutamate receptors, glycine receptors, and the 5-HT serotonin receptor. Benzodiazepines are positive allosteric modulators of GABA A receptors and enhancing GABA A mediated chloride channel opening. Voltage-gated channels respond to changes in membrane potential. So voltage-gated sodium channels propagate action potentials, while voltage-gated calcium channels contribute to muscle contraction and neurotransmitter release. Local anesthetics block voltage-gated sodium channels, and verapamil blocks L-type calcium channels. Other channels are regulated by intracellular second messengers. Because ion flow begins immediately after channel opening, ion channels produce effects within milliseconds. So remember, these are our fastest receptors. GPCR signaling, or G-protein coupled receptors, cross the membrane several times. When a ligand binds, the receptor causes the G-alpha subunit to exchange a GDP for a GTP. G-alpha separates from G-beta gamma, and both components can regulate enzymes or ion channels. The signal ends when G-alpha hydrolyzes GTP back to GDP, and the complex reassembles. GS stimulates adenylyl cyclase, increasing CAMP, or cyclic AMP, and activating protein kinase A. GI inhibits adenylyl cyclase, decreasing cyclic AMP. Its beta-gamma subunits can also regulate ion channels. GQ activates phospholipase C, producing IP3 and DAG. IP3 releases calcium from the endoplasmic reticulum, while DAG activates protein kinase C. A component memory aid here is that GS stimulates CAMP, GI inhibits CAMP, and GQ increases calcium. Okay, and then this slide here is just to put exactly what I just said about the different receptors in one just visual, if you're more of a visual learner here. So, and then it's ranked from, shortest to longest in terms of their response. So just take a moment to appreciate this little diagram, and we'll keep on trucking. So drug responses can change with repeated exposure, right? So chronic stimulation by an agonist may cause desensitization and receptor downregulation. Receptors can become phosphorylated and temporarily uncoupled from signaling, internalized into the cell, or degraded. With fewer functional receptors, the same dose produces a smaller response, contributing to what's called tolerance. Chronic antagonist exposure often produces the opposite adaptation, right? So persistent receptor blockade may cause receptor upregulation and sensitization. If the antagonist is suddenly discontinued, the increased number of sensitivity of receptors can produce an exaggerated rebound response. Patients also differ because of drug concentrations at the receptor, endogenous ligand levels, receptor number and function, genetics, age, organ function, disease severity, and compensatory physiology. The high yield pattern here is chronic agonist exposure causes downregulation, whereas chronic antagonist exposure causes upregulation. Absorption is the movement of an unchanged drug from its administration site into the systemic circulation. After administration, a drug must be absorbed, enter the bloodstream, distribute into tissues, and reach its target. Intravenous drugs are the major exception because they are placed directly into systemic circulation, so there's no absorption required there. Passive absorption is favored by a steep concentration gradient, small molecular size, a non-ionized state, high lipid solubility, a large absorptive surface, and a permeable membrane. Good blood flow also increases absorption by carrying the drug away from the site and maintaining the concentration gradient. Only free drug readily crosses most membranes. Transport proteins may increase uptake or pump drugs back out, while disease and tissue damage can alter membrane permeability. The simplest rule is that small, non-ionized, lipid-soluble molecules cross lipid membranes most easily. Drugs cross biological membranes through several mechanisms. Lipid diffusion is the most common. A drug dissolves in the membrane and moves down its concentration gradient without a carrier or energy. It works best for small non-ionized lipid-soluble drugs. Aqueous or paracellular diffusion allows small water-soluble molecules to pass through pores or between cells. Its importance depends on pore size and tissue permeability. Facilitated diffusion uses a carrier, but still moves the drug down its gradient, so it does not require energy. Because a carrier is involved, the process is selective, saturable, and subject to competition. Active transport also uses carriers, but it can move drugs against a gradient using ATP, or energy stored in another ion gradient. Endocytosis surrounds and internalizes large molecules and is particularly important for some proteins and other biological drugs. Many drugs are weak acids or weak bases that exist in equilibrium between ionized and non-ionized forms. The non-ionized forms is generally more lipid soluble and crosses cell membranes more easily. The ionized form is the more water soluble and crosses lipid membranes fairly poorly. A weak acid can be written as HA in its protonated non-ionized form and A- in its deprotonated ionized form. An acidic environment favors HA, increasing the fraction capable of passive membrane diffusion. A weak base exists as a protonated BH+, which is ionized, or unprotonated B, which is non-ionized. A basic environment favors B and therefore improves passive membrane crossing. The high-yield rule is that weak acids become less ionized in acidic environments, while weak bases become less ionized in basic environments. Non-ionization favors passive diffusion, although surface area, blood flow, and permeability remain important. I just like to remember that, going all the way back to Gen Chem in college and high school, whatever, remember the whole rule of like dissolves like. It can relatively be applied here, right? An acid can be absorbed in an acidic environment. A base can be absorbed in a basic environment. And we'll get into the opposite in a second here with ion trapping and whatnot, but just kind of to give you a framework for how to think about this. The pKa is the pH at which a weak acid or base is 50% ionized and 50% non-ionized. For every 1 unit difference between pH and pKa, the ratio between the two forms changes by a factor of 10. 2 units create a 100-to-1 ratio, and 3 can create a 1,000-to-1 ratio. Low pH favors protonated forms. For a weak acid, the protonated form, again, is that HA, and it's non-ionized. For a weak base, the protonated form is BH+. It has a charge, so it is ionized. High pH favors deprotonation. So deprotonation for a weak acid looks like A-. It lost that proton, so now it has a negative charge. Then for a weak base, a non-ionized form just looks like B, right? So it's non-ionized. No charge. Ion trapping occurs when a drug crosses a membrane in its non-ionized form and then becomes ionized in the new compartment. It cannot diffuse back. Therefore, the weak acid becomes trapped on the more basic side, while the weak base becomes more trapped on the acidic side. It's just putting them in a little cage. It's like, hey, yeah, come on. It's almost like those little wasp traps where they can fly in, but they can't fly out. That's exactly what you're doing here. And then the chart at the bottom here, what you would do is you would take the pH of the given acid or the drug that they give you. It can be an acid or a base. And then you subtract its pH by the pKa of the environment. And then based on the number you get at the top, right, -4, -3, -2, yada, 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 you can see how much is absorbed or unionized, okay, right? Because those two are interchangeable in this scenario. But do memorize this table. Either memorize the acid portion or the base portion. And then from there, you can just flip the numbers and you'll have the opposite. So if you memorize the acid, just memorize the acid and then just flip the numbers to get the base numbers, or just memorize the base and then flip the numbers and you'll get the acid numbers. But do memorize this because there are plenty of problems regarding this. So bioavailability is represented by F, and it is the fraction of an administered dose that reaches systemic circulation unchanged. So intravenous administration has a bioavailability of 1 or 100% because the entire dose enters circulation directly. Other routes usually have a lower or more variable bioavailability. Oral bioavailability may be reduced by incomplete absorption, intestinal metabolism, efflux transporters, and hepatic first-pass metabolism. An oral drug passes through the intestinal wall and portal circulation before reaching the liver, where part of it may be metabolized before entering systemic circulation. Sublingual and most parenteral routes avoid first-pass metabolism. Like, for example, rectal administration partially avoids it because venous drainage differs between the upper and lower rectum. When converting an IV dose to an oral dose, a simplified relationship is oral dose equals IV dose divided by oral bioavailability, assuming equivalent exposure and linear pharmacokinetics. And again, for the more visual learners in a more organized fashion, here's just a table discussing exactly what we just talked about, and you can just take a moment to appreciate it and then keep on going. And the next couple of slides are just these charts. But to just kind of talk through it, oral administration is convenient, inexpensive, and generally safe, but absorption can vary with food, other drugs, gastrointestinal motility, gastric pH, and formulation. Oral drugs may also have reduced bioavailability because of that first-pass metabolism, and this route requires a functioning GI tract and patient cooperation. You also have rectal administration, which is useful when patients are vomiting, unconscious, or unable to swallow. It partially avoids first-pass metabolism, but absorption may be erratic. It can also cause local irritation and may not be acceptable by every patient, right? Not everybody wants a little something up their bum. Sublingual and buccal drugs are absorbed through those oral mucosa, and this can produce that rapid response and avoids hepatic first-pass metabolism. However, only relatively small doses can be delivered. The drug must remain in contact with the mucosa, and absorption may be incomplete if it's swallowed. And here's that next chart here. So talking about parenteral routes of administration. So intravenous administration requires no absorption and provides immediate, complete bioavailability. It allows precise dosing and rapid adjustment, but once administered, the drug cannot be recalled. IV use also carries risks such as infection, hematoma, rapid toxicity, and difficulty obtaining access. Intramuscular absorption depends on the formulation and local blood flow. Aqueous solutions are absorbed relatively quickly, while depot preparations produce slow, sustained release. Intramuscular injections avoid first-pass metabolism, but can be painful and may injure nerves, and should be used cautiously in patients with bleeding disorders. And then you have subcutaneous administration, which also avoids first-pass metabolism and is convenient for drugs such as insulin. Absorption is usually slower than intramuscular absorption and depends on tissue blood flow. Only small volumes can be given here, and irritating drugs may damage the tissue. So then we have some other routes of administration here with our final chart, and this is just topical administration, places a drug on the body surface, such as skin, eye, nose, or vagina, primarily to produce a local effect. Absorption varies by site and surface area. Local irritation can occur, and some drugs may still enter systemic circulation. Transdermal administration is specifically designed to create a systemic effect through the skin. Patches can provide slow, sustained delivery and avoid first-pass metabolism. Drugs must generally be potent and sufficiently lipid-soluble to cross that skin barrier. Inhaled drugs have rapid access to the lungs because of their large surface area and rich blood supply, and this route is ideal for local treatment of airway diseases, but systemic absorption may also occur here. So then inhaled delivery can irritate the respiratory tract, and effective administration often depends on proper inhaler technique. All right, so distribution is the reversible movement of a drug between the systemic circulation and body tissues. After entering the bloodstream, free drug can move into tissues, bind receptors, undergo metabolism, or be filtered by the kidneys, as we've said before. The major fluid compartments help predict where a drug may distribute. In a typical 70-kilogram adult, plasma is about 4 liters. Extracellular fluid is about 14 liters. Intracellular fluid is about 28 liters. And total body water is about 42 liters. These are approximations that vary with age, sex, body composition, etc. But, just good numbers to know. Protein-bound drug generally remains within the circulation and acts as a reservoir. Only free drug, remember, can pass those membranes, produce the receptor effects, undergo metabolism, and be eliminated. First-pass metabolism reduces how much orally administered drug reaches systemic circulation and is therefore available for distribution. So distribution depends on characteristics of both the drug and the tissue. Small, lipid-soluble, non-ionized drugs cross biological membranes most easily, like we've said, and then plasma protein binding tends to retain the drug in the bloodstream, while tissue's binding pulls the drug out of the plasma and may create a tissue reservoir. Blood flow determines how quickly a drug reaches a given organ. Highly perfused tissues, including the heart, lungs, kidney, liver, and brain, receive the drug first. Muscle and skin receive it more slowly, while fat and bone usually have the slowest initial distribution. Capillary permeability also differs among tissues. Leaky capillaries permit easier movement, whereas protective barriers restrict entry. Tissue composition and transport proteins further influence how much drug enters and remains. And in short, though, perfusion determines how quickly a drug arrives, while tissue affinity helps determine how much accumulates. Capillary structure varies among organs, producing major differences in drug distribution. So the liver has highly permeable sinusoidal capillaries with large openings, allowing many small and large substances to move between blood and tissue. The pancreas and GI tract tissues have fenestrated capillaries that permit many low molecular weight substances to cross. Heart and skeletal muscle have continuous capillary endothelium. Small molecules can move through intracellular spaces, while lipid-soluble drugs can cross endothelial membranes. The central nervous system is the most restrictive, so tight junctions between endothelial cells form what's called the blood-brain barrier with no large pores or fenestrations. Drugs generally need to be sufficiently lipid-soluble or use specific transporters to enter the brain. Efflux transporters, such as P-glycoprotein, may then pump certain drugs back into the bloodstream. All right, and now this concept that we've kind of talked about ad nauseum, but just giving it its own slide. We're thorough here at MooseMed. So many drugs bind reversibly to plasma proteins. Albumin primarily binds acidic and neutral drugs, including warfarin, naproxen, phenytoin, and many sulfonamides. Alpha-1 acid glycoprotein primarily binds basic drugs such as lidocaine and tricyclic antidepressants. Protein-bound drug does not readily cross membranes. Remember, they act as that reservoir. So thus, they do not bind receptors, undergo glomerular filtration, or produce an immediate pharmacological effect. It acts as a circulating reservoir. Okay, that's the big takeaway here. Free drug can leave the bloodstream, enter tissues, bind receptors, and undergo metabolism or excretion. Two drugs may compete for the same binding site, temporarily increasing the free fraction of a displaced drug. The body often compensates, though, through distribution and clearance, but displacement can become clinically important with highly bound, narrow therapeutic index drugs or impaired elimination. High plasma binding generally lowers VD, whereas extensive tissue binding raises VD. And what VD even is, we will get into in a couple slides. All right, so pharmacokinetic compartment models simplify how drugs move through the body. The central compartment includes blood and highly perfused organs such as the heart, lungs, liver, kidney, and brain. These tissues receive drugs rapidly. The peripheral compartment includes more slowly perfused tissues, as we've said, like muscle, skin, fat, and bone, and drugs enter and leave these tissues more slowly. After an intravenous bolus, plasma concentration is initially very high. A rapid early decline may occur as the drug distributes from blood into tissues, and this is the distribution phase. Once distribution approaches equilibrium, the slower terminal decline is dominated by elimination. A one-compartment model treats the body as if distribution were immediate and uniform. A multi-compartment model better represents movement between blood and different tissues. The key point is that an early decrease in plasma concentration does not necessarily mean the drug has already left the body. Right, and here is that VD, volume of distribution. So, volume of distribution, or VD, relates the amount of drug in the body to its measured plasma concentration. It is calculated as the amount of drug in the body divided by the plasma drug concentration. So VD is the apparent volume, not necessarily a real anatomical space. A low VD means much of the drug remains measurable in the plasma. This is common with large, charged, water-soluble, or highly plasma protein-bound drugs. A VD near 4 liters suggests plasma coefficient, while approximately 14 liters suggests extracellular fluid distribution. So if it's lower, it means that it's going to be in the plasma, where if it's higher, it means it's probably going to be an extracellular fluid. Whereas a VD near 42 liters suggests distribution throughout total body water. A very high VD indicates that little drug remains in the plasma because it accumulates in fat or binds extensively in tissues. A useful memory aid here is that low VD means that the drug stays in the blood. Okay, so low VD drug stays in the blood. And then a high VD means that it hides in tissues, okay? All right, so now we get to the fun part of all of this, which is like the very little amount of math you get to do as medical students. I mean, I don't know about you, but I went into this field because it had no math. I don't know if that was the best decision, but here we are. But honestly, with this, I just recommend practice problems, practice problems, practice problems. I'll talk through this, but really the way to get this in your brain is just practice, practice, practice. The faster you can do these, the better, because these will be free points on the exam, right? If you just know how to do the given formula and know how to rearrange stuff, you're all well and good. My personal advice for this, if you're cramming this the night before and you don't know literally anything, have units be your guiding light. Some professors will make you do some pretty annoying unit conversions, and even though they're basic, a unit conversion is a unit conversion, so it's annoying. But in most cases for like board exams and more standardized exams, you don't get a calculator or anything, and they kind of know that most medical students aren't the best at math. So they don't make you do a lot of unit conversions. So anyway, but regardless, please practice these just in your own time. This is the way to do it. With that said, calculating VD and loading dose. Volume of distribution equals the amount of drug in the body divided by its plasma concentration. So if a 2,000 milligram IV dose produces a concentration of 28.5 milligrams per liter, the VD is approximately 70.2 liters. For a 70 kilogram patient, that's about 1 liter per kilogram. When VD is given in liters per kilogram, multiply it by the body weight to obtain total liters. For example, 0.4 liters per kilogram multiplied by 75 kilograms equals 10.5 liters. VD also determines the loading dose needed to reach a target concentration. Loading dose equals VD times the desired concentration divided by bioavailability. For a 60 kilogram patient with a VD of 2 liters per kilogram, total VD is 120 liters. Multiplying by 3 milligrams per liter and dividing by 0.9 gives a loading dose of 400 milligrams. So that was a lot of math, but like I said, just practice, and this will become pretty goo-goo gaga pretty quickly. All right, so the primary purpose of biotransformation is to convert lipid-soluble drugs into more polar compounds that can be eliminated in urine or bile. It occurs mainly in the liver, although the intestine and other tissues also contribute here. Metabolism can have 4 outcomes. First, it may convert an active drug into an inactive or less active metabolite, reducing its effect. Second, it can activate a prodrug, meaning metabolism is necessary for therapeutic activity. I like to think of prodrugs as little eggs that you have to break open to get to the yummy yolk, right? Like the actual good drug, the good thing, right? Third, it may create another active metabolite that prolongs the drug's effects or contributes to toxicity. Fourth, it may generate a reactive or toxic metabolite. Acetaminophen metabolism illustrates the final outcome because a small fraction of it is converted into what's called NAPQI. Under normal conditions, glutathione detoxifies this NAPQI. In an overdose, glutathione becomes depleted and NAPQI damage can just spread throughout your hepatocytes. Metabolism, therefore, does not always simply just turn off a drug. Okay, so phase 1 reactions introduce or expose a functional group on the drug. The major reactions are oxidation, reduction, and hydrolysis. Oxidation is commonly performed by cytochrome P450 enzymes. Phase 1 often increases polarity and may prepare a compound for phase 4. The phase 1 product may be inactive, remain active, activate a prodrug, or become reactive and toxic. Phase 2 reactions conjugate the drug or its metabolite with an endogenous polar group. Examples include glucuronidation, oh my god, we're doing this again, sulfation, acetylation, and glutathione conjugation. Conjugation usually increases water solubility and promotes elimination in the urine or bile. The product is usually inactive, although exceptions exist. The 2 phases do not have to occur sequentially. A drug may undergo phase 1 only, phase 2 only, or both. But just remember that phase 1 exposes, phase 2 conjugates and disposes. Okay? I just like to remember that phase 1 is very gen chem heavy, right? You're doing redox and hydrolysis. Like those are the 2 most common chemistry topics in regards to chemical reactions. So I just remember phase 1 is redox and hydrolysis, and thus it's going to increase that polarity. Whereas phase 2 is just the other thing, which is conjugation. It's just going to change it around by adding different groups on there to increase the polarity even more, okay? But the whole purpose of it is to promote that elimination, urine or bile. It's going to conjugate it into a less active form that can be peed out. So these are the high-yield cytochrome P450 enzymes that my program needs to know. these are just pretty high yield. So I'm going to run through these. So cytochrome P450 enzymes perform many phase 1 oxidative reactions. CYP3A4 metabolizes a large portion of commonly used drugs and is found in both the liver and intestinal mucosa, making it a frequent source of drug interactions and first-pass metabolism. I like to remember this one because it's the only one with like a 3 in it, and also the 3 kind of looks like an intestine, so you can remember that it has to do with GI stuff. And since it's the only one with a 3, you can remember that it's like a pretty important one since it's used commonly for most drugs. CYP2D6 metabolizes many antidepressants, beta blockers, and opioids. It has substantial genetic variability and converts codeine into morphine. I like to remember this one because it is the only one with a D in it, so I remember that it's used for antidepressants. And then beta blockers and opioids kind of follow suit there for me. CYP2C9 metabolizes warfarin, phenytoin, and several NSAIDs. Reduced activity can increase drug exposure and bleeding risk with warfarin. CYP2C19 activates clopidogrel, so loss of a function variance may reduce its antiplatelet effect. CYP1A2 metabolizes caffeine, theophylline, clozapine, and olanzapine, and is induced by compounds in cigarette smoke. Then you have CYP2E1, which is induced by chronic alcohol exposure and contributes to acetaminophen conversion into the toxic metabolite NAPQI. That one I find easier to remember too because of the E in there for ethanol, so you can remember that it's alcohol related, and thus NAPQI kind of falls in there as well. With the ones in the middle there that I kind of didn't give an easy way to remember, like just write them out, put them on a couple flashcards, run it a couple times. All right, so again, we're thorough here at MooseMed. I just have a dedicated page to these major phase 2 pathways. So phase 2 metabolism conjugates drugs with endogenous groups, usually increasing water solubility and elimination. All right, it's our third time around the sun. I should get it this time. Glucuronidation, oh my gosh, okay, is performed by UGT enzymes and is one of the most common pathways. It is also essential for bilirubin clearance. So immature UGT activity contributes to neonatal jaundice, which we'll cover towards the end of this video. Sulfation adds sulfate and is important in acetaminophen metabolism, although it has a lower capacity than glucuronidation. Acetylation uses NAT enzymes, NAT, and varies genetically. Slow acetylators may experience greater toxicity, while rapid acetylators may clear certain drugs too quickly. Methyltransferases include COMT, which metabolizes catecholamines, and TPMT, which metabolizes thiopurines. Low TPMT activity increases myelosuppression risk. And then finally, glutathione conjugation detoxifies reactive compounds such as NAPQI. And importantly, it's got to be that reduced glutathione. All right, so getting into acetaminophen poisoning, right? So at therapeutic doses, most acetaminophen undergoes glucuronidation or sulfation and is safely eliminated. A small fraction is oxidized by CYP enzymes, particularly CYP2E1, that ethanol one that we talked about, into NAPQI, a highly reactive metabolite. Normally, glutathione rapidly conjugates and detoxifies NAPQI. During an overdose, though, glucuronidation and sulfation become overwhelmed, directing more acetaminophen into CYP pathways. As NAPQI production increases, hepatic glutathione stores become depleted. Unbound NAPQI then attaches to hepatocyte proteins, potentially causing severe hepatic necrosis and acute liver failure. N-acetylcysteine is the antidote here. It restores glutathione availability and can also help detoxify NAPQI directly. It is most effective when given early on, but treatment may still provide a benefit in later presentations. Enzyme induction increases the amount or activity of metabolic enzymes. Because new enzyme synthesis is often required, induction typically develops over days to weeks and may persist after the inducer is stopped. For an active parent drug, induction usually increases metabolism, lower drug concentration, and can cause therapeutic failure. For a prodrug, induction may increase formation of the active metabolite, increasing either benefit or toxicity. It may also increase production of toxic metabolites. The little egg metaphor about prodrugs is pretty applicable here, right? Before you can actually make it useful, you have to metabolize the egg to get to the yolk. You have to break open the shell to get to the yolk. Enzyme Enzyme inhibition decreases metabolic activity and often develops more rapidly. For an active parent drug, inhibition can increase concentration and toxicity. For a prodrug, it can reduce activation and therapeutic benefit. Therefore, the consequence of induction or inhibition cannot be predicted until we know whether metabolism inactivates the parent drug or activates a prodrug or creates a toxic metabolite. Several commonly encountered substances induce drug metabolizing enzymes. Rifampin, for example, induces CYP3A4, CYP2C9, and CYP2C19, potentially reducing the effectiveness of warfarin, hormonal contraceptives, antivirals, and then immunosuppressants. Bear with me now. Carbamazepine induces CYP3A4 and also induces its own metabolism, a process called autoinduction. Phenytoin and phenobarbital induce multiple pathways and may lower concentrations of warfarin, hormonal contraceptives, and other drugs. St. John's wort induces CYP3A4 and P-glycoprotein, creating important interactions despite being sold as an herbal supplement. Chronic alcohol exposure induces CYP2E1 and may increase that NAPQI production that we talked about. Compounds in cigarette smoke induce CYP1A2, lowering concentrations of drugs such as thiophylline, clozapine, and olanzapine. Azole antifungals inhibit CYP3A4, and some also inhibit CYP2C9 or CYP2C19. This may increase concentrations of susceptible statins, warfarin, benzodiazepines, and immunosuppressants. Among the macrolides, erythromycin and clarithromycin inhibit CYP3A4. Azithromycin produces fewer CYP-mitigated interactions. Amiodarone inhibits several pathways, including CYP2C9, CYP3A4, and P-glycoprotein, potentially increasing warfarin or digoxin exposure. Cimetidine, sorry guys, I'm not a pharmacist. I'll get these pronunciations eventually, is a broad CYP inhibitor. Ritnovar and Cobistat strongly inhibit CYP3A4 and are intentionally used to boost certain antiviral concentrations, although they also create numerous interactions. Grapefruit inhibits intestinal CYP3A4, increasing the oral bioavailability of susceptible drugs. Fluoxetine and paroxetine inhibit CYP2D6 and may reduce tamoxifen activation while increasing exposure to some beta blockers. So, like I said, just refer to these charts. These are just some high-yield ones provided by my professor that are just good to know. You got big inducers, big inhibitors. Flip between the two and stare at them. Put some on some flashcards. All right, now we're getting into the nitty-gritty of the active and prodrug stuff. So the effect of an enzyme interaction depends on what metabolism is doing to the drug. For an active parent drug, induction generally increases metabolism, and thus it lowers the parent drug concentration. Its therapeutic effects may decrease, creating a risk of treatment failure. Inhibition does the opposite. Metabolism slows down, so the active parent drug can hang around for a bit and accumulate, and thus toxicity actually becomes more likely. A prodrug, remember our little egg, must be metabolized into its active form. You got to break the egg to get to the yolk. Enzyme induction may increase activation and potentially increase both therapeutic effects and toxicity, whereas enzyme inhibition does the opposite, so will reduce activation and cause treatment failure. If metabolism produces a toxic metabolite, induction may increase toxicity by creating more of that metabolite. Inhibition may reduce toxic metabolite production, but it can simultaneously cause the parent compound to accumulate. So always identify the activity of both the parent drug and its metabolites. Drug metabolism varies substantially among patients. First-pass metabolism in the intestinal wall and liver reduces the bioavailability of many drugs, but can be avoided with routes that we stated, such as sublingual, transdermal, and parenteral administration. Neonates have immature CYP enzymes and conjugation pathways, which may prolong drug half-lives. Older adults often have reduced hepatic blood flow and may have decreased phase 1 metabolism. Liver disease can reduce functioning hepatocyte mass, enzyme activity, and hepatic perfusion, increasing drug accumulation and toxicity. Heart failure, shock, and advanced cirrhosis also reduces liver blood flow, especially affecting high extraction drugs. Renal dysfunction matters even for hepatically metabolized drugs because active or toxic metabolites may depend on the kidneys for elimination and can accumulate when renal function declines. Genetic variation can substantially change drug metabolism. Poor CYP2D6 metabolizers may receive little analgesia from codeine, while ultra-rapid metabolizers may generate excessive morphine and develop toxicity. CYP2C19 loss-of-function variants reduce clopidogrel activation. Reduced CYP2C9 activity increases warfarin exposure, and low TPMT activity creates a major risk of thiopurine-induced myelosuppression. Inflammation can also suppress CYP enzymes. During severe infection, malignancy, or systemic inflammation, drug clearance may decrease and adverse effects may be more likely. Environmental exposure matters as well here, so like cigarette smoke induces CYP1A2, while smoking cessation can raise concentrations of its substrates. Grapefruit inhibits intestinal CYP3A4, whereas chronic alcohol exposure induces that CYP2E1 and may increase NAPQI formation. I know we've covered this multiple times, but I'm trying to cover it from multiple angles just so you hear it multiple times before you get to those flashcards, etc. But seriously, the best way to just memorize these, use my little mnemonics here and there when I provide them, and then just throw some on a flashcard. Okay, so pharmacogenomics, the big picture here. So pharmacogenetics and pharmacogenomics examine how genetic variation influences drug exposure. Pharmacogenetics traditionally focuses on one gene and its relationship with a particular medication, whereas pharmacogenomics takes a broader approach by considering variation across many genes or the entire genome, hence pharmacogenomics. So genetic variation can alter pharmacokinetics by affecting absorption, distribution, metabolism, and elimination. They can also change pharmacodynamics by altering drug targets or downstream signaling. Some variants increase susceptibility to unexpected adverse reactions, while others influence disease biology and the response to targeted therapies. The comparison between identical and fraternal twins illustrate that inherited factors can influence drug half-life. The ultimate goal is precision medicine, right? Selecting the most appropriate drug and dose for an individual while improving efficacy and reducing toxicity. Okay, and finally we have genetic variation. So an allele is one of several alternative forms of a gene found at the same chromosomal location. A polymorphism is a DNA sequence variation that is relatively common within a population, historically often defined as having a frequency of at least 1%. Common variations include single nucleotide polymorphisms, insertions or deletions, also known as indels, gene duplications, coding region variations, and regulatory or other non-coding variants. These changes may alter the structure, abundance, or activity of a protein. A person typically inherits one allele from each parent. The pair of alleles at a gene is the genotype, or when describing paired haplotypes, the diplotype. Clinicians and laboratories may translate that genetic result into a predicted phenotype, such as poor, intermediate, normal, rapid, or ultra-rapid metabolism. All right, so codeine and tamoxifen demonstrate how CYP2D6 variation affects drugs that require metabolic activation. CYP2D6 converts part of codeine dose into morphine and much more potent mu opioid agonist that provides much of codeine's analgesic effect. Analgesic, by the way, means no more pain. So poor or intermediate metabolizers produce less morphine and may receive inadequate pain relief. Ultra-rapid metabolizers, though, may produce morphine way too quickly, increasing the risk of a profound sedation and respiratory depression. Tamoxifen is converted through several pathways into an active metabolite, including endoxifen, with CYP2D6 playing an important role. Reduced CYP2D6 function, or strong CYP2D6 inhibition, lowers endoxifen concentrations and may reduce treatment effectiveness. The central lesson is that reduced metabolism of prodrug produces less active drug, not more. And just another example here, but it was just one that was called high yield by my professor, and they brought it up, so I'm bringing it up here. Thiopurine S-methyltransferase, or TPMT, is a phase 2 enzyme that methylates and inactivates thiopurine drugs, and these medications include azithromycin, 6-mercaptopurine, there we go, and thioguanine, and are used in leukemia and several autoimmune disorders. With normal TPMT activity, part of the drug is inactivated, limiting the concentration of active thiopurine metabolites. With low or absent TPMT activity, less drug is inactivated and active metabolites start to accumulate. The major danger here is severe, potentially life-threatening bone marrow suppression. So this may appear as leukopenia, thrombocytopenia, and anemia. Low TPMT activity therefore does not cause treatment failure. It causes excessive exposure and toxicity. So genetic or enzyme activity testing can help guide the starting dose, but continued blood count monitoring remains fairly important. All right, and then another example here. So we have OAT-P1B1, which is an uptake transporter on the sinusoidal surface of hepatocytes, and it moves several drugs from the bloodstream into liver cells, influencing their distribution, metabolism, and biliary elimination. The transporter is encoded by the gene SLC-O1B1. Statins provide an important example here. So with normal transporter function, susceptible statins are efficiently taken into hepatocytes with their therapeutic target, where their therapeutic target is located, and systemic exposure remains lower. Reduced OAT-P1B1 function means less statins enter the liver and more remains in the systemic circulation. Increased exposure of skeletal muscle can cause myalgia or myopathy, and in severe cases, rhabdomyolysis. This association is particularly important for simvastatin, and so transporter genetics can therefore affect drug toxicity is the big takeaway here. So even when the metabolic enzymes themselves function normally, right, transporter genetics are important. All right, so glucose 6-phosphate dehydrogenase, or G6PD, is an X-linked enzyme that generates NADPH. Red blood cells need NADPH to maintain glutathione in its reduced form. Reduced glutathione protects hemoglobin and the red cell membrane from oxidative injury. In G6PD deficiency, red blood cells have limited protection against oxidative stress. So exposure to an oxidant medication, certain foods, or an infection may damage hemoglobin and the cell membrane, causing acute hemolysis. Important drug triggers include primaquine, dapsone, and some sulfonamide antibiotics. Clinical clues include sudden anemia, jaundice, dark urine, fatigue, and weakness after a new exposure or infection. The medication does not directly remove red cells. It creates an oxidative stress that overwhelms their deficient antioxidant defense. So pharmacokinetic elimination. All right. So drug elimination includes both metabolism and excretion. Metabolism chemically transforms the drug, like we've discussed, while excretion, well, it gets rid of it. It physically removes the parent drug or its metabolites from the body. Clearance describes the body's overall ability to eliminate the drug. Half-life describes how quickly the amount or concentration changes. With repeated dosing, drug accumulates until the rate entering the body equals the rate being eliminated, and this is what's called steady state. The dosing goal is to remain within the therapeutic window, above the minimum effective concentration, but below that toxic concentration. A loading dose can rapidly establish the target concentration, while maintenance dosing replaces the drug eliminated over time. Loading dose is primarily determined by volume of distribution, whereas maintenance dosing is primarily determined by clearance, right? You need to know how much is being lost if you want to maintain it, and then you need to know how the distribution of said drug before you administer it, hence the loading dose. All right, and here we have renal drug elimination. So renal drug excretion reflects three processes, right? GFR, or glomerular filtration. We have active tubular secretion and tubular reabsorption. During glomerular filtration, only free unbound drug enters the filtrate. And say it with me now, protein-bound drug remains in circulation, right? Active secretion transports drugs from peritubular blood into proximal tubule. Because this process uses transporters, it can be saturable and subject to competition. As water is removed from the tubule, lipid-soluble non-ionized drugs may passively diffuse back into the blood. Polar ionized drugs cross membranes poorly, so they remain trapped in the tubular fluid and are peed out. Net renal excretion equals filtration plus secretion minus absorption. So when kidney function declines, renally cleared drugs and active metabolites may start to accumulate, requiring dose or dosing intervals adjustment. So clearance is the apparent volume of plasma completely cleared of drug per unit time, commonly expressed in liters per hour. It is not the amount of drug removed, it describes the efficiency of said elimination, right? Because we just talked about elimination. That is what is about drug being removed. This is about the efficiency of it. So clearance equals the elimination rate divided by plasma concentration. In first-order kinetics, clearance remains constant even though the absolute elimination rate decreases as the concentration falls. Total clearance is the sum of clearance by the kidneys, liver, and other routes. Clearance also equals volume of distribution multiplied by the elimination rate constant. Half-life can be calculated as 0.693 times volume of distribution divided by clearance. Therefore, increasing volume of distribution prolongs half-life if clearance stays constant. Increasing clearance shortens the half-life if volume of distribution stays constant. Clearance is especially important for determining the maintenance dose needed to sustain a target concentration. Okay, so in first-order kinetics, a constant fraction of a drug is eliminated per unit time. The absolute amount removed becomes smaller as concentration falls, producing an exponential decline and a constant half-life. Most drugs follow first-order kinetics at therapeutic concentrations. In zero-order kinetics, the elimination pathway is saturated, so constant amount, not a constant percentage, is eliminated per unit time. Concentration declines linearly, clearance is no longer constant, and there is no fixed half-life. Because the elimination machinery is already operating near capacity, a small dose increase can produce a disproportionate rise in drug concentration. Classic examples include ethanol, phenytoin at higher concentrations, and high-dose salicylates. Some drugs can transform from first order toward capacity-limited kinetics as concentrations start to increase. All right, so half-life is the time required for the amount of concentration of a drug to decrease by 50% during the first-order elimination. After one half-life, 50% remains. After 2, 25% remains. After 3, 12.5. After 4, 6.25. And after 5, approximately 3.1%. And therefore, roughly 97% of the drug has been eliminated after 5 half-lives. And in pharmacology, that's essentially gone. The same rule applies in opposite direction during repeated dosing. It takes approximately 4 to 5 half-lives to approach a steady state, regardless of the dose. So it also takes 4 to 5 half-lives to approach a new steady state after dosing changes. So a loading dose can reach target concentrations immediately, but it does not shorten the time required for the underlying elimination process to reach steady state. All right, so a single dose concentration curve shows how plasma drug concentration changes after a single non-intravenous dose. Lag time is the delay before the drug first appears in the bloodstream. As absorption continues, the concentration rises to Cmax, the maximum measured plasma concentration. Tmax is the time at which Cmax occurs. The clinical effect begins when concentration first exceeds the minimum effective concentration. Duration of action is time spent above that threshold. So the upper boundary represents the concentration at which an adverse effect becomes unacceptable, and at the range between these boundaries is the therapeutic window. Increasing the dose generally raises Cmax and total exposure and may extend the duration of action. However, it also increases possibility that concentrations will enter a toxic range. So the rate of The rate of absorption describes how quickly a drug enters systemic circulation. Faster absorption generally produces the earlier Tmax and a higher Cmax. So slower absorption produces a later, lower peak and may prolong the effects. Controlled release formulations intentionally slow absorption and reduce concentration fluctuations. The extent of absorption describes how much unchanged drug ultimately reaches systemic circulation. It is reflected by bioavailability and the area under the concentration time curve, or AUC. The concepts are related but distinct here. So two formulations may deliver the same total amount of drug and therefore have similar AUCs while producing different Cmax and Tmax values. Alternatively, they may also have similar rates but different total bioavailability. So rate mainly changes the curve's shape while extent determines total systemic exposure. All right, so accumulation in steady state. So with repeated dosing, some drug remains when the next dose is administered. So concentration, therefore, accumulates until the rate of drug administration equals the rate of elimination. This equilibrium is, like we said, called steady state. For first-order kinetics, the approach to steady state follows the half-life. After one half-life, approximately 50% of final steady state concentration is reached, and after 275, and et cetera, until we're at 5, and we reach about 97%. So a longer half-life means slower accumulation and a longer time to steady state. Increasing the dose raises the final steady state concentration, but does not reduce the number of half-lives required. After a dose change, another 4 to 5 half-lives are needed to approach the new steady state. All right, so under linear pharmacokinetics, average steady state concentration equals bioavailability multiplied by dosing rate divided by clearance. And dosing rate is the dose divided by the dosing interval. This relationship means that doubling the dose doubles the average steady state concentration. Giving the same dose twice as frequently also doubles the dosing rate and therefore doubles average concentration. In contrast, doubling clearance cuts the steady state concentration in half. To calculate the maintenance dose given during each interval, multiply the target steady state concentration by clearance in the dosing interval, then divide by bioavailability. The central idea is that maintenance dosing replaces what the body eliminates. Increasing dose rate or bioavailability raises steady state concentration, while increasing clearance lowers it. Reduced clearance can cause accumulation and toxicity unless the dose or dosing interval are adjusted. So average steady state concentrations is determined by dose rate, bioavailability, and clearance. Fluctuation around that average is influenced mainly by the dosing interval relative to the drug's half-life and by rate of absorption. Using the same total daily dose, smaller and more frequent doses produce lower peaks and higher troughs. Larger, less frequent doses produce higher peaks and lower troughs. Continuous IV infusion produce the least fluctuation, while extended release formulation reduce fluctuation by slowing absorption. Minimizing these changes helps prevent peak concentrations from entering the toxic range and trough concentrations from falling below a therapeutic range. This is especially important for drugs with a narrow therapeutic window. However, dosing convenience and adherence must also be considered when choosing how frequently a medication is administered. All right, so a loading dose rapidly brings that drug concentration to its target. It's calculated as volume of distribution multiplied by the target concentration divided by bioavailability, and loading dose is therefore primarily determined by volume of distribution. Loading doses are useful when a drug has a long half-life or when treatment must begin quickly. They do not change clearance or shorten the drug's half-life, but if a large loading dose is administered, it could cause toxicity during administration. It may be divided into smaller portions. So a maintenance dose replaces the amount eliminated during each dosing interval. It is calculated using clearance, the target steady state concentration, the interval, and bioavailability. And reduced clearance generally requires a lower dose, a longer interval, or both. So the exam shortcut here is loading dose, you want to be thinking volume of distribution. Maintenance dose, you want to be thinking clearance. All right, now we're getting into more legal stuff, less science, but as doctors, you're part lawyer, part physician, honestly, so it's good stuff to know. So let's get into drug development. All right, so drug development begins with identifying and validating a biological target. Researchers then find compounds that interact with this target, optimize promising leads, perform preclinical testing, and develop a usable formulation. Before most human testing even begins, the sponsor submits what's called an IND application, or an investigational new drug application. Clinical trials then evaluate the drug in people. If the evidence supports an acceptable benefit-risk balance, the sponsor submits a market application for FDA review. Approval is followed by continued post-marketing safety monitoring because uncommon or delayed adverse effects may not become apparent or may not be apparent in just a small clinical trial. Their overall goal is to demonstrate efficacy, safety, product quality, and reliable manufacturing. So FDA describes the process in 5 broad stages: discovery and development, preclinical research, clinical research, regulatory review, and post-market monitoring. FDA drug development overview. There you go. All right, so getting into the drug development steps here. So target identification begins by selecting a biological structure involved in disease. Targets are commonly receptors, enzymes, ion channels, transporters, or other proteins. Target validation asks whether altering that structure is likely to improve the disease. So researchers use genetic, biochemical, cellular, and pharmacological evidence to examine target's importance and evaluate the potency and selectivity of potential interventions. During hit identification, large numbers of compounds may be screened to find those that interact with the target. A hit demonstrates activity but is rarely suitable for immediate clinical use. So lead optimization chemically modifies promising compounds to improve potency, selectivity, solubility, bioavailability, metabolic stability, and other drug-like properties. Researchers simultaneously try to reduce toxicity and off-target effects until a developmental candidate is selected. So with preclinical testing, it occurs before the routine human trials and uses in vitro and in vivo studies to examine pharmacodynamics, pharmacokinetics, ADME, toxicology, and preliminary safety. These studies help identify major hazards and support selection of an initial human dose. Formulation work develops a stable dosage form that delivers the drug predictably by its intended route. The investigational new drug application, or IND, includes preclinical evidence, manufacturing information, clinical protocols, investigator information, dosing plans, and safety monitoring procedures. FDA's initial review period is about 30 days, and a study may begin earlier if FDA notifies the sponsor that they may proceed, or after 30 days if the FDA has not imposed a clinical hold. All right, so getting into some drug names. So the generic name is the non-proprietary name of the active drug ingredient, such as metformin. A brand name is the proprietary trade name used for a particular manufacturer products, such as glucophage. A conventional generic drug product contains the same active ingredient as its reference product and generally matches its dosage, form, strength, route, and intended use. Approval occurs through an abbreviated new drug application, or ANDA. The applicant must demonstrate pharmaceutical equivalence, bioequivalence, and consistent manufacturing quality. And then you also have biologics, which are generally larger, structurally more complex products manufactured using living systems. So examples include monoclonal antibodies, vaccines, and recombinant proteins. Many biologics are approved through a biologics license applications, or BLA, rather than a conventional new drug application. So generic approval involves 2 related ideas. Pharmaceutical equivalence means that generic and reference products contain the same active ingredient, strength, dosage form, and route of administration. Bioequivalence asks whether the body is exposed to the drug similarly. Investigators compare measures such as Cmax, representing peak concentration, and AUC, representing total exposure. And generally, the entire 90% confidence interval for the generic to reference ratio must fall between 80% and 125%. The exam trap here is interpreting that correctly. It doesn't mean that the generic contains 20% less medication or is 20% less effective. Approved generics are expected to provide the same clinical benefit when used as labeled, right? So the FDA's Orange Book is a list of therapeutic equivalence evaluations. All right, so again, biologics are large, complex products produced using living systems, so they cannot be reproduced as exact molecular copies as easily as the conventional small molecule drug. So a biosimilar must be highly similar to its reference biologic with no clinically meaningful differences in safety, purity, or potency. Approval therefore relies on extensive analytical comparisons along with appropriate pharmacokinetic, pharmacodynamic, immunogenicity, and clinical evidence. Interchangeability is a separate designation related to pharmacy-level substitution. Depending on state law, an interchangeable biosimilar may be substituted without first contacting the prescriber. A biosimilar without that designation can still be prescribed and is not considered less safe or less effective. Remember that the Orange Book is for generics, whereas the Purple Book here is for biologics and biosimilars. This definitely will not get tested, but this is just, little anecdotes that as growing physicians, good to know. Now we actually get into the testable part of this, which are the clinical trial phases. So the 4 clinical trial phases answer progressively different questions. So phase 1 just asks whether the drug is reasonably safe and explores tolerability, pharmacokinetics, pharmacodynamics, and an appropriate drug dose range. It usually involves a relatively small group, often healthy volunteers, although areas such as oncology commonly enroll patients. Phase 2 asks whether the treatment appears to work in patients with the target disease and helps identify the optimal dose. Phase 3 uses a much larger and more diverse population to confirm efficacy, compare treatment with the control, and provide the main pre-approval benefit-risk evidence. Phase 4 occurs after approval, when broad real-world use can reveal rare, delayed, or unexpected adverse effects and provide information about long-term effectiveness. All right, so with randomization, controls, and blinding, these design features help separate a true treatment effect from bias. So randomization assigns participants by chance, reducing selection bias and helping distribute both known and unknown confounders between groups. A control group provides the comparison needed to interpret what would have happened without the experiment happening. The control might receive a placebo, standard therapy, or another active drug. Blinding reduces the influence of expectations. So in a single blind study, participants usually don't know their assignment. In a double blind study, participants and investigators don't know. An open label study makes the assignment known to everyone. So although open label designs are more vulnerable to bias, they may be necessary when blinding would be impractical or unethical. So in a parallel group study, each participant receives one assigned treatment and remains in that group. This prevents carryover between treatments and works well when the disease progresses over time or when treatment effects are persistent. The trade-off is that more participants are usually needed because outcomes are compared between different people. In a crossover study, each participant receives multiple treatments in sequence and serves as their own control. This reduces interpatient variability and may require fewer participants. However, a sufficient washout period is essential here. Crossover designs work best for stable chronic conditions with reversible outcomes and short-lived treatments. So they should be avoided when the disease changes substantially. The treatment produces an irreversible or prolonged effect, or adequate washout is impossible. So an endpoint is the outcome used to judge what happened in a clinical trial. The primary endpoint is the main outcome the study was specifically designed to assess. It must be defined in advance, measurable, and clinically relevant because it drives the trial's main conclusion. Secondary endpoints provide additional supportive information such as quality of life or hospitalization rates. A surrogate endpoint is different. It is a biomarker or intermediate measurement expected to produce a meaningful clinical benefit. LDL, cholesterol, and hemoglobin A1C are common examples of this. Surrogates can make trials shorter and more feasible, but they have an important limitation. Improving a laboratory value does not automatically prove the patients live longer, feel better, or experience fewer clinically important events. So, statistical power is the ability of a study to detect a genuine treatment effect when one exists. Power generally increases with a larger sample size or larger treatment effect and decreases when outcome variability is high. An underpowered study may miss a real benefit. Conversely, an extremely large study may find a statistically significant difference that is too small to matter clinically. Confounders and bias can also distort rules. So examples include placebo, a nocebo, observer expectations, poor adherence, and difference in comorbidities, medications, age, sex, lifestyle, or genetics. Investigators manage these problems with randomization, blinding, carefully chosen eligibility criteria, stratification, and appropriately planned subgroup analysis. So statistical significance should therefore always be interpreted alongside a study's design and clinical importance. The Belmont report describes three foundations or three principles for human subject research. So respect for persons means recognizing autonomy, obtaining meaningful informed consent, ensuring participation is voluntary, and protecting people with diminished autonomy. Beneficence means maximizing potential benefits while minimizing the possible harms. It also requires scientifically valid research because exposing participants to risk in a poorly designed study cannot produce meaningful benefit. Justice addresses fairness. So research burdens and potential benefits should be distributed equitably. Participants should be selected fairly, and vulnerable populations should not be exploited. A useful memory aid is autonomy, benefit, and fairness, corresponding to respect for persons, beneficence, and justice. So IRB, or an institutional review board, reviews human subject research before it begins. The IRB evaluates scientific validity, the balance of risk and benefits, risk minimization procedures, participation selection, and informed consent process. It may also monitor the study's continuing ethical compliance. Informed consent is not simply a signature on a form, it is an ongoing communication process. Participants should understand the study's purpose, procedures, risks, possible benefits, alternatives, and confidentiality protections. Participation must be voluntary, and participants may withdraw without penalty. Ethical selection also matters. Trial populations should reasonably reflect the people expected to use the treatment. So language, transportation, cost, time away from work, mistrust, and overly restrictive eligibility criteria can create underrepresentation and limit whether study findings generalize to real patients. And here's just an FDA submission map for you. So these application names correspond to different points in development, right? So an IND, or an investigational new drug application, provides the information needed before most human clinical testing can begin, including preclinical, manufacturing, protocol, and investigator information. After successful trials, an NDA requests marketing approval for a new small molecule drug. A BLA serves a similar marketing purpose for a biologic while addressing its more complex manufacturing and characterization. An ANDA is the abbreviated pathway for a generic drug, so it relies mainly on pharmaceutical equivalents and bioequivalents, so new efficacy trials are usually unnecessary. Finally, a supplemental NDA proposes a change to an approved drug, such as a new indication, formulation, dosage, patient population, or labeling update. So there you go, just a quick little cheat sheet for all these abbreviations. All right, so special and expedited FDA pathways. So these pathways all speed access or encourage development, but they accomplish different things. An emergency use authorization is temporary permission during a declared emergency and is not full FDA approval. This was used during COVID. Orphan designation supports development for rare diseases through financial and regulatory incentives. Fast track and breakthrough therapy both target serious conditions, but breakthrough therapy requires preliminary clinical evidence suggesting substantial improvement and provides more intensive FDA guidance. Accelerated approval allows earlier approval using a surrogate endpoint that is reasonably likely to predict a benefit, followed by confirmatory studies. And then finally, you have priority review, which simply shortens the review timeline for a completed application. It does not reduce the evidence required, but there you go. So the exam strategy is to identify exactly what part of the process is being accelerated. All right, and now we're getting into the more genetic side of this video. So we're going to put pharmacology a bit on hold. We will come back to it, trust me, when we actually get into the nitty-gritty of every single drug. But now we're kind of transition into some genetics review. So, big picture. Genetic disease is much broader than a mutation in a single gene. A disorder may result from a pathogenic single gene variant, an abnormal chromosome number, a structural chromosome rearrangement, a mitochondrial DNA variant, or an abnormal epigenetic regulation such as imprinting. Even when two patients have a change in the same gene or chromosome, their phenotypes may differ. Severity depends on the exact type of change, when it occurred, how it was inherited, and which proportion of cells it carries it. For example, a variant present in every cell may produce a different phenotype from one confined to a subset of tissues. The big idea is that genetic diagnosis identifies the alteration, but its timing, distribution, and biological consequence determines the clinical presentation. All right, so a variant is simply a difference in DNA sequence. The word itself does not imply disease. Variant is interchangeable with mutation. Mutation does not inherently mean bad, right? Variants may be benign, pathogenic, or classified as having uncertain significance. An allele is one specific version of a gene or DNA sequence. A polymorphism is a relatively common variant, traditionally defined by a minor allele frequency of at least 1%. A de novo variant is a newly present in the patient variant and was not inherited from either parent. It may arise in a parental gamete or during development after fertilization. Genetic changes can result from DNA replication or repair errors, abnormal recombination, radiation, chemicals, or infectious agents. A major clinical principle is that newly discovered variants should not automatically be assumed to explain a patient's disease. So genetic variants can be categorized and organized by the amount of DNA involved. So a single nucleotide variant changes only one nucleotide. An insertion or deletion, called an indel, adds or removes a relatively small number of base pairs. Larger changes are classified as structural variations and include major deletions, duplications, inversions, and translocations. A copy number variant is a deletion or duplication that changes how many copies of a DNA segment or gene are present. Repeat expansions are different. An existing short DNA sequence is repeated an abnormally large amount of times. Several repeat expansion disorders demonstrate anticipation, meaning the repeat may enlarge in later generations and cause earlier or more severe damage. So the size category helps determine which genetic test is most likely going to detect this abnormality. All right, so mosaicism means that one person has two or more genetically different cell populations derived from a single fertilized egg. It occurs when a genetic change develops after fertilization. So the earlier that change occurs, the more tissues it can affect and the more extensive the phenotype may be. Somatic mosaicism involves body cells and usually is not transmitted unless germ cells are also affected. Gonadal mosaicism specifically involves a proportion of egg or sperm precursor cells. So this explains how clinically unaffected parents may have more than one child with the same apparently de novo disorder. Chimerism is fundamentally different because the genetically distinct cells originate from more than one fertilized egg, such as through fusion of two early embryos. So just remember, mosaic equals one zygote, which is chimera equals multiple zygotes. And that just makes sense with what chimera is, traditionally speaking, right? It's like that mixed up creature. It's multiple things in one, right? It's the lion, it's the snake, it's the scorpion, it's the bat. And so just remember, chimera, multiple zygotes, mosaic, one zygote. A normal human karyotype contains 46 chromosomes, usually 46XX or 46XY. Polyploidy means having more than two complete haploid sets. Triploidy, for example, contains 3 complete sets and may occur when 2 sperm fertilize 1 egg or when a diploid gamete participates in fertilization. Aneuploidy is different because it involves the gain or loss of an individual chromosome rather than an entire set. Its most common mechanism is non-disjunction when homologous chromosomes or sister chromatids fail to separate properly. After fertilization, an extra chromosome produces a trisomy, while a missing chromosome produces a monosomy. So keep this distinction clear, right? Polyploidy changes complete chromosome sets, whereas aneuploidy changes the number of particular chromosomes. So there are three major autosomal trisomies that are compatible with life at birth, which are trisomies 21, 18, and 13. So trisomy 21, or Down syndrome, is associated with hypotonia, characteristic facial features, intellectual disability, congenital heart disease, and increased risk of leukemia and early Alzheimer's disease. Trisomy 18, or Edwards syndrome, commonly causes severe growth restriction, clenched fists with overlapping fingers, a small jaw, congenital organ defects, and major developmental impairment. Trisomy 13, or Patau syndrome, is associated with severe developmental disability, brain abnormalities such as holoprosencephaly, cleft lip or palate, polydactyly, and congenital heart disease. So trisomies 13 and 18 generally have a much poorer survivability than trisomy 21. But for exams, just connect each trisomy to its distinctive pattern rather than just memorizing isolated findings. All right, so structural abnormalities occur when chromosomes break and are repaired incorrectly. So a deletion removes the genetic material, a duplication repeats it, and an inversion reinserts a segment in the opposite direction. A ring chromosome forms when chromosomes' ends are lost or broken and then are joined together. A translocation moves material between chromosomes. The critical distinction is whether the rearrangement is balanced, right? A balanced translocation has no major net gain or loss of DNA, so the carrier may appear clinically unaffected. However, chromosome segregation during gamete formation can produce unbalanced eggs or sperm, creating a risk of infertility, miscarriage, or an affected child. An unbalanced translocation directly produces extra or missing genetic material and is therefore more likely to cause an abnormal phenotype. Microdeletion and microduplication syndromes are copy number disorders involving several neighboring genes. 22q11.2 deletion causes what's called DeGeorge syndrome and may produce congenital heart defects, palatal abnormalities, learning difficulties, thymic dysfunction with recurrent infection, and hypoparathyroidism. 7q11.23 deletion causes what's called Williams syndrome, and it includes loss of the elastin gene and is associated with supravalvular aortic stenosis, characteristic facial features, and a distinctive developmental and behavioral profile. A deletion of the short arm of a chromosome 5 causes Cri-du-chat syndrome, or cry of the cat syndrome, characterized by a high-pitched cat-like cry in an infant. They also have microcephaly and significant developmental impairment. So these abnormalities are often detected with chromosomal microarray rather than routine karyotype. All right, so eggs always contribute an X chromosome, while sperm contribute either an X or a Y, therefore determine chromosomal sex. So the X chromosome is large and contains many genes, whereas the Y chromosome is smaller and contains relatively few. To prevent XX cells from expressing approximately twice as many X-linked gene products as XY cells, one X chromosome is largely inactivated early in embryonic development. This process is generally random, so some cells retain the maternal X, while others retain the paternal X. As a result, females are functionally mosaic for X-linked gene expression. Some genes escape an activation, so the process is not complete. X inactivation and the limited number of Y-linked genes also help explain why sex chromosome aneuploidies are often better tolerated than autosomal aneuploidies. All right, so sex chromosome aneuploidies are generally more compatible with life than autosomal aneuploidies because extra X chromosomes are largely inactivated and the Y chromosome contains relatively few genes. So Turner syndrome, or 45X, is associated with short stature, gonadal dysgenesis, delayed puberty, and infertility. Patients should also be evaluated for congenital cardiac abnormalities, especially coarctation of the aorta and renal abnormalities. Klinefelter syndrome, or 47XXY, causes primary testicular failure, producing small testes, low testosterone, infertility, and some gynecomastia. Triple X and 47XYY often produce mild or unrecognized phenotypes, although learning or language difficulties may occur. One exam point is that X inactivation is incomplete. Genes that escape inactivation, including the SHOX gene, help explain the characteristic changes in structure. Autosomal dominant disease requires only one pathogenic allele, so it therefore tends to show vertical transmission with affected people appearing in successive generations. Males and females are affected equally, and father-to-son transmission is possible. A heterozygous affected parent has 50% chance of transmitting the variant with each pregnancy. Autosomal recessive diseases require two pathogenic alleles, so the parents are commonly unaffected carriers, so the condition may appear unexpectedly or skip a generation. When two carriers have a child, each pregnancy has a 25% chance of an affected child, a 50% chance of a carrier, and a 25% chance of neither variant. So these possibilities reset with every pregnancy, but it's just the pedigree shortcut, right? So dominant disorders tend to look vertical, while recessive disorders appear more horizontally among siblings. All right, so the defining clue for X-linked inheritance is the absence of father-to-son transmission, because a father gives his son a Y chromosome. In X-linked recessive disease, males are affected more frequently because they possess only one X chromosome. A carrier mother transmits the variant to half of her sons and half of her daughters, so the sons who inherit it are generally affected, while daughters are generally carriers. An affected father passes his variant to every daughter, but none to his sons, because he only gives the Y. In X-linked dominant disease, an affected father has all affected daughters and no affected sons, while heterozygous mothers have a 50% risk for every child. Hemophilia A and Duchenne's muscular dystrophy are classic recessive examples. One nuance, Fragile X has a complex repeat expansion pattern and does not behave like a simple X-linked dominant disorder. All right, so coding variants are categorized by their effect on proteins. A synonymous or silent variant changes a codon without changing its amino acid because the genetic code is redundant. So it may still occasionally affect splicing or expression, so silent doesn't always mean biologically irrelevant. A missense variant substitutes one amino acid for another with effects ranging from negligible to severe. So sickle cell disease is the classic example here. So valine replaces glutamate and beta globin, and then causes sickle cell. Then you have a nonsense variant, which converts an amino acid codon into a premature stop codon. So commonly producing a truncated protein or causing the messenger RNA to be destroyed through nonsense-mediated decay. A splice site variant disrupts RNA processing and may cause exon skipping or intron retention, which, a little reminder, introns need to be cut out. The key question is always how the DNA change alters the amount or function of the final protein. For an insertion or deletion within a coding region, ask whether the number of nucleotides involved is divisible by 3. If it is, then the variant is in frame, which means whole amino acids are inserted or removed, but the downstream codon boundaries remain intact. The protein may still be abnormal, but the remaining sequence is read normally. If the number is not divisible by 3, then the reading frame has shifted. Every downstream codon then changes, and a premature stop codon usually appears shortly afterward. Frame shift variants, therefore, commonly cause severe loss of protein function. A familiar contrast comes from the dystrophin gene. In frame deletions are more often associated with a milder Becker muscular dystrophy, whereas out-of-frame deletions produce Duchenne's muscular dystrophy. So the fast exam rule is that multiples of 3 preserve the frame. Anything else will shift it and most likely cause a lot more catastrophic events. Repeat expansion disorders result from unstable tandem DNA sequences that can lengthen when passed to the next generation. So this explains anticipation. So the condition appears at an earlier age or within greater severity in successive generations. The repeat sequence and its location determine the mechanism. So Huntington's disease involves CAG repeat in the coding region of the HTT gene, producing an expanded polyglutamine tract and toxic protein. Myotonic dystrophy type 1 involves a CTG repeat in the 3' untranslated region of DMPK, producing toxic RNA effects. Fragile X-associated disorders involve a CGG repeat in the 5' untranslated region of FMR1, and a full mutation causes methylation and silencing of FMR1. Remember that anticipation is not merely observational, right? It reflects progressive expansion of an unstable repeat, often with apparent of origin effect. Mitochondrial DNA is small, circular, double-stranded genome containing approximately 16,500 base pairs and 37 genes. 13 of these genes encode oxidative phosphorylation proteins, while the remainder encode ribosomal and transfer RNAs needed for mitochondrial translation. Most mitochondrial proteins are actually encoded by nuclear DNA and imported into the organelle. Mitochondrial DNA has a relatively high mutation rate and is inherited almost exclusively from the mother because the embryo's mitochondria come from the oocyte. Therefore, an affected mother may transmit a mitochondrial variant to her sons and daughters, but an affected father does not transmit it to his children. Pedigrees may look maternal, but disease severity can vary enormously between relatives because inheriting the variant does not guarantee that every cell or tissue receives the same proportion of abnormal mitochondrial DNA. Homoplasmy means that mitochondrial DNA copies are essentially identical. Heteroplasmy means that normal and mutant mitochondrial genomes coexist within a cell or person. During cell division and oocyte formation, mitochondria are distributed randomly through a process called replicative segregation. Different cells and even different children of the same mother can therefore receive very different mutation loads. Symptoms emerge when proportions of abnormal mitochondrial DNA exceed a tissue-specific threshold. High-energy tissues such as brain, skeletal muscle, heart, retina, and peripheral nerves are especially vulnerable because they depend heavily on oxidative phosphorylation. This combination of heteroplasmy, threshold effects, and replicative segregation explains the remarkable variability of mitochondrial disease. Even relatives carrying the same variant may have different organs affected and very different severities. Epigenetics refers to stable changes in gene expression that occur without changing the underlying DNA sequence. So up until this point, we've been talking about mutations where you're actually literally changing, the DNA. This is just changing accessibility to it is the easiest way to put it. So DNA methylation commonly occurs at cytosine and CpG sites and is generally associated with compact chromatin and reduced transcription, especially when promoter CpG islands are methylated. So when you see methylation, you want to think, we don't want that DNA. We are silencing it. We don't want it to be transcribed. Histone acetylation usually has the opposite effect. So adding acetyl groups reduces the attraction between the histones and negatively charged DNA, opening chromatin and increasing access for transcription machinery. So histone deacetylation removes those groups and usually represses expression. Other mechanisms include chromatin remodeling complexes and regulatory RNAs, and these are useful general rules, although the exact effect can depend on genomic location and context. The central distinction is that a genetic variant changes the DNA letters, whereas an epigenetic change alters how those letters are packaged, accessed, or expressed. All right, so genomic imprinting is a parent of origin-dependent gene expression. For an imprinted gene, one parental allele is epigenetically silenced, so the phenotype depends on whether the functional or abnormal allele came from the mother or the father. Imprints are erased in developing germ cells and are then reestablished according to that individual's sex. Thus, a woman establishes maternal imprints in her oocytes, even on chromosomes she originally inherited from her father. A man establishes paternal imprints in his sperm. The embryo then receives one maternal and one paternal imprint pattern. Because only one allele may be active, deleting or silencing that active copy can cause disease even when the DNA sequence of the other copy is normal. The classic clinical comparison is chromosome 15, loss of a paternal expression produces what's called Prader-Willi syndrome, whereas loss of a maternal expression produces Angelman syndrome. And these are definitely high yield. I just remember that loss of the parental one causes Prader-Willi because it starts with a P, and then loss of the maternal gene causes Angelman because, moms love their little angels, their little babies. So it's an easy way to remember it. All right, so uniparental disomy, or UPD, means that both copies of a chromosome come from the same parent instead of one from each parent. This can result from events such as trisomy rescue, where an embryo initially has 3 copies and loses one. In heterodismy, the child receives both different homologs from one parent, usually reflecting a meiosis 1 error. In isodissemy, the child receives two identical copies of one homolog, often reflecting a meiosis 2 error or chromosome duplication. UPD, or uniparental dissemy, can cause a disease in two main ways. First, it can create an abnormal parent-specific imprinting pattern. And second, isodissemy may make a recessive pathogenic variant homozygous, even if only one parent carries it. So Prader-Willi and Angelman syndrome, we touched on it in one of the previous slides, but now we're going to do a bit of more of a deep dive into it. But it involves the same imprinted region on chromosome 15, but phenotype depends on which parental expression is lost. So Prader-Willi syndrome results from that loss of a normally active paternal gene, so coming from the dad, and this may occur through a paternal deletion or maternal uniparental dissemy. Infants often have hypotonia and feeding difficulty, followed later by hyperphagia, obesity, hypogonadism, and developmental disability. Angelman syndrome results from a loss of the maternal UBE3A expression in the brain. So patients commonly have severe developmental disability, minimal speech, seizures, ataxic movements, and a characteristically happy or excitable disposition. So the essential memory line here is that absent paternal expression causes Prader-Willi, whereas absent maternal expression causes Angelman. And keeping that mnemonic that I used a couple slides ago, Prader, paternal, maternal is Angelman, because moms love their little angels, right? Their little angels. All right, so now we're going to be shifting gears from the genetics-heavy stuff into just more general information, and then we're going to wrap around back to pharmacology at the very end, where we're just it's basically just gonna be a drug boogaloo, all right? We're just gonna go one drug after the other. But for the meantime, welcome to diagnostic imaging. So diagnostic imaging should begin with a clinical question rather than simply asking which modality produces the best picture, right? So imaging may establish a diagnosis, guide a procedure, plan a treatment, or monitor disease over time. Each modality has characteristic strengths. So X-rays are quick and useful for bone and the chest. CT provide rapid cross-sectional imaging and is valuable in emergencies. MRI produces excellent soft tissue detail, and ultrasound often offers real-time imaging without ionizing radiation. Nuclear medicine and PET, or PET, show physiology or molecular activity rather than anatomy alone. And so basically selecting a test, therefore, requires balancing the structure being examined, the urgency, radiation, and contrast the risks, patient characteristics, and availability. So the best image is the one that answers the clinical question safely and efficiently. So structural versus functional imaging. So structural imaging answers what does anatomy look like. X-ray, CT, MRI, and ultrasound can demonstrate features such as fractures, hemorrhages, masses, organ enlargements, or structural malformations. Functional imaging instead asks, what is the tissue doing? So PET and other nuclear scans can evaluate metabolism, perfusion, receptor activity, or organ function. Functional MRI is another example, so it indirectly maps changes in the brain activity through alterations in blood oxygen. Or blood oxygenation. So these categories can complement one another. So for example, a PET scan may reveal metabolically active cancer while the accompanying CT shows its precise anatomical location. Functional abnormalities may also appear before a major structural change becomes visible. So the important distinction is therefore anatomy and morphology versus physiology and molecular activity. All right, so a high-yield imaging distinction is whether the modality uses ionizing radiation. So conventional X-rays and CT use externally generated X-rays, while nuclear medicine and PET detect radiation emitted by an administered radiotracer. MRI and ultrasound do not use ionizing radiation. CT generally exposes the patient to more radiation than a single conventional radiograph because it collects numerous projections to construct a cross-sectional image. Avoiding ionizing radiation is particularly important in children and in pregnancy when an alternative can answer the question, although necessary imaging should not be withheld when its benefits outweigh the risk. So MRI avoids radiation but introduces concerns involving strong magnetic fields, implants, and long acquisition times. So the memory thing here is just that X-ray, CT, and nuclear medicine count as radiation, whereas MRI and ultrasound do not. So sensitivity begins with patients who truly have the disease and asks how many test positive. It equals true positives divided by all diseased patients. So a highly sensitive test has few false negatives. This supports the mnemonic snout. A negative result on a highly sensitive test helps rule disease out. Specificity begins with patients who do not have the disease and asks how many test negative. It equals true negatives divided by all non-diseased patients. So a highly specific test has few false positives. This gives the mnemonic spin. A positive result on a highly specific test helps rule disease in. So positive predictive value asks how likely disease is after a positive result. Unlike sensitivity and specificity, predictive values depend strongly on prevalence. As prevalence rises, positive predictive values generally rise and negative predictive values fall. All right, so nuclear medicine differs from the conventional radiology because the radiation source is placed inside the patient as a radio tracer. So the scanner then detects where that tracer accumulates, providing information about metabolism, perfusion, and organ function. So in FDG PET, tissues with increased glucose utilization take up more tracer. This makes PET valuable for cancer staging and treatment monitoring, but increased uptake is not specific for malignancy. Infectious and inflammatory tissues may also be active. Other nuclear studies evaluate bone turnover, thyroid activity, mitochondrial perfusion, or renal function, and these tests may detect functional abnormalities before structural changes become apparent, although their anatomic detail is limited. So for that reason, PET is commonly combined with a CT or MRI so that metabolic activity can be localized to a specific structure. Imaging selection is pattern recognition guided by clinical setting. So CT is fast and commonly chosen for acute emergencies such as trauma or suspected intracranial hemorrhage. MRI takes longer but provides superior soft tissue contrast, making it useful for brain, spinal cord, joints, and many soft tissue lesions. Ultrasound is portable, real-time, and radiation-free, making it valuable in pregnancy and gallbladder, vessels, and procedural guidance. X-ray remains an efficient first study for many bone and chest questions. Nuclear medicine and PET, like I said, are always useful when question concerns metabolism, perfusion, organ function, or cancer staging. And also remember the contrast associations. So iodinated contrast is used with radiography and CT, gadolinium with MRI, and radio tracers with nuclear medicine. All right. So the simplest way to master the autonomic map is to begin with what is universal. So every autonomic preganglionic neuron releases acetylcholine onto a nicotinic neuronal receptor in a ganglion. Parasympathetic postganglionic neurons also release acetylcholine, but it binds muscarinic receptors on the target organ. So most sympathetic postganglionic neurons release norepinephrine onto alpha or beta androgenic receptors. The major exception is sympathetic innervation of sweat glands, which release acetylcholine onto muscarinic receptors. The adrenal medulla functions like a modified sympathetic ganglion. So preganglionic acetylcholine activates nicotinic receptors on the chromaffin cells, causing epinephrine and norepinephrine to release into the blood. Finally, the somatic motor system is different. It uses one neuron that releases acetylcholine onto a nicotinic muscular receptor at skeletal muscle. All right, so just touching on what I just said, but just separating out those exceptions so we can focus on them here. So most sympathetic postganglionic neurons release norepinephrine, like we've said, but three important exceptions deserve some special attention. So first, sympathetic nerves supplying eccrine sweat glands release acetylcholine, which activates M3 muscarinic receptors and produces sweating. Second, the adrenal medulla acts like a modified sympathetic ganglion. Preganglionic acetylcholine activates nicotinic neuronal receptors on chromaffin cells, causing epinephrine and some norepinephrine to enter the bloodstream. Third, dopamine can activate D1 receptors in renal and other vascular beds, producing vasodilation. And this is primarily a pharmacologic receptor effect rather than the usual sympathetic neurotransmitter pattern. The memory framework is just that all autonomic ganglia use nicotinic receptors. Parasympathetic effector organs use muscarinic receptors, and sympathetic effector organs are usually, but not always, androgenic. All right, so Ionotropic receptors are ligand-gated ion channels. When the ligand binds, the channel opens directly, ions move across the membrane, and the response occurs within milliseconds. Nicotinic acetylcholine receptors are the major autonomic example here, so sodium enters, potassium exits, and the membrane depolarizes. Metabotropic receptors are G-protein-coupled receptors. They do not form the channel themselves. Instead, they activate G-proteins, enzymes, second messengers, and sometimes other ion channels. Their responses are slower, but they can be amplified and last longer. Muscarinic and androgenic receptors are metabotropic. Also, remember that neurotransmitter release begins presynaptically when an action potential opens voltage-gated calcium channels. Calcium entry then triggers vesicular exocytosis. Organize autonomic GPCRs using the mnemonic KISS. Okay, so alpha 1 is GQ, alpha 2 is GI, beta 1 and beta 2 and beta 3 are GS. GQ activates what's called phospholipase C, increasing IP3 and DAG and intracellular calcium. This generally promotes smooth muscle contraction or glandular secretion. GI inhibits adenylyl cyclase and lowers cyclic AMP. Presynaptic alpha-2 receptors use this pathway to decrease norepinephrine release, while cardiac M2 receptors reduce heart rate and conduction. GS stimulates adenylyl cyclase and raises cyclic AMP. Beta 1 therefore stimulates the heart and renin release, whereas beta 2 and beta 3 generally relax smooth muscle. For muscarinic receptors, odd numbers M1 and M3 and M5 are GQ, while even numbers M2 and M4 are GI. For my program, though, the only muscarinic receptors that were really mainly highlighted were M3 and M2, and the rest you can kind of, keep in the back of your mind. But those are the ones that we called attention to, so I'm going to do the same here. But for completion's sake, here are all of them. All right, so the acetylcholine life cycle. So acetylcholine synthesis begins when choline enters the presynaptic terminal, which is the rate-limiting step, and it can be blocked by something called hemicholinum. And this isn't necessarily high yield. This was just on the diagram, and my professor threw it up, so I'm keeping it in here. Choline acetyltransferase then combines choline with acetyl-CoA to form acetylcholine. Vesicular acetylcholine transporter packages it into vesicles and is inhibited by a drug called vesimicol. An action potential opens calcium channels, and calcium-dependent exocytosis releases acetylcholine. But botulism toxin can block this release by disrupting vesicle fusion proteins. So acetylcholine then activates nicotinic and muscarinic receptors, and unlike norepinephrine, its signal is terminated primarily through enzymatic destruction. So this is where acetylcholinesterases come in, and acetylcholinesterase rapidly converts acetylcholine into acetate and reusable choline. Therefore, acetylcholinesterase inhibitors, which we will cover, increase and prolong acetylcholine activity at every cholinergic synapse they can reach, right? If you destroy the thing that's destroying your drug, then you're going to have more drug. Now, on the flip side, we have the norepinephrine life cycle. So norepinephrine synthesis begins with tyrosine. Tyrosine hydroxylase converts tyrosine to DOPA, which is the rate-limiting step and is inhibited by metirosine. And so DOPA becomes dopamine, and VMAT transports dopamine into vesicles. Reserpine blocks VMAT and depletes stored catecholamines. So inside the vesicle, dopamine is converted to norepinephrine, and calcium-dependent exocytosis releases norepinephrine, a process that guanethidine can inhibit. And like I said, all these drugs that I'm bringing up, they were just on my professor's diagram. They weren't necessarily high yield, but it's there. So if you have extra space in your brain, it's good to maybe write it down, but I wouldn't really pay too much attention to this. I'm just being thorough. But then norepinephrine can then activate alpha or beta adrenergic receptors. And the major difference from acetylcholine is how the signal ends here, okay? So pay attention to this. So norepinephrine is removed mainly by reuptake into the presynaptic neuron through the norepinephrine transporter, or NET, okay? And we'll cover some drugs that deal with this. But as a little teaser, we have cocaine and tricyclic antidepressants, which inhibit these NETs, increasing norepinephrine within the synaptic cleft and prolonging that adrenergic stimulation. All right, so cholinergic receptors are divided into nicotinic and muscarinic families. So nicotinic receptors are ligand-gated cation channels and therefore act rapidly. NN receptors are located in autonomic ganglia, the adrenal medulla, and parts of the central nervous system. NP M, okay, receptors are located at the skeletal muscle neuromuscular junction, and both produce depolarization. So muscarinic receptors are going to be GPCRs, all right, and M2 receptors are especially important in the heart, where GI signaling lowers cyclic AMP and opens potassium channels, decreasing that heart rate, AV node conduction, and atrial contractility. M3 receptors use GQ and increase intracellular calcium. In glands, this increases secretion. In most smooth muscle, it causes contraction. Consequently, M3 activation produces meiosis, bronchoconstriction, increased GI activity, bladder emptying, and sweating from sympathetic cholinergic nerves. Instead of memorizing receptors in isolation, connect them to organ function. So in the heart, sympathetic beta 1 stimulation increases rate, contractility, and conduction, while parasympathetic M2 activation decreases them. In the lungs, beta 2 produces bronchodilation and reduces secretions, whereas M3 causes bronchoconstriction and increases secretions. Most blood vessels receive predominantly sympathetic control, so alpha 1 constricts the vessels, while beta 2 dilates selected vascular beds, especially those supplying skeletal muscle. Glandular responses depend on both the division and receptor. So parasympathetic M3 stimulation produces abundant watery saliva and tears, whereas sympathetic alpha 1 stimulation produces a smaller, thicker salivary secretion. Sweat glands are more memorable exception here because sympathetic nerves release acetylcholine, which again activate those M3 receptors to cause sweating. All right, so this diagram summarizes the coordinated effects of two autonomic divisions. Again, it's just more of a visual for you to kind of organize your thoughts and just if you needed something to look at. So parasympathetic activity constricts the pupil for near vision, increases watery salivation, constricts bronchi, slows the heart, increases GI motility and secretion, and promotes urination through detrusor contraction with sphincter relaxation. Sympathetic activity generally prepares the body for exertion. Alpha 1 dilates the pupil by contracting radial muscle. Beta 2 relaxes bronchial smooth muscle. Beta 1 stimulates the heart, and alpha 1 contracts GI and urinary sphincters. In the bladder, beta 3 mediated detrusor relaxation and alpha 1 mediated sphincter contraction promote storage. And so the useful physiologic theme here is that parasympathetic activity favors digestion and elimination, whereas sympathetic activity favors ventilation, circulation, energy use, and storage of urine. All right, so autonomic tone is the baseline activity present before a drug is given. It explains why blocking a receptor may have a large effect in one organ but little effect in another. At rest, parasympathetic tone generally dominates the heart, GI tract, and bladder, while sympathetic tone maintains most vascular resistance. For example, blocking cardiac muscarinic receptors with atropine increases heart rate because it removes substantial resting vagal inhibition. Autonomic divisions may work reciprocally, as in the bladder, so storage requires detrusor relaxation and sphincter contraction, while voiding requires the reverse. They can also change together to produce a coordinated response, such as the baroreceptor control of heart rate. Clinically, receptor blockade has its largest effect where the pathway has strong resting tone. Right, so the baroreceptor reflex. So the baroreceptor reflex is the body's rapid response to sudden changes in blood pressure. So when blood pressure falls, stretch of the carotid sinus and aortic arch, baroreceptors decrease, so they fire less. The medulla responds by increasing sympathetic activity and decreasing parasympathetic activity. So heart rate, contractility, and vasoconstriction increase, pushing blood pressure back up. So when blood pressure suddenly rises, the opposite occurs. So greater stretch in the baroreceptor firing happens. This decreases sympathetic output and increases vagal activity, producing vasodilation and reflex bradycardia. Bradycardia, slow heart rate. So for exam questions, separate a drug's direct action from the reflex response. And this will be more important when we discuss tracing, but we'll get to that later. And so going back to this, an alpha-1 agonist directly causes vasoconstriction and raises blood pressure, but the resulting baroreceptor reflex may slow the heart. So a receptor's effect depends not only on its G protein, but also on the signaling machinery within the target cell. Beta receptors in cardiac and smooth muscle both activate GS, increasing cyclic AMP and protein kinase A. In cardiac muscle, pKa increases calcium entry and calcium availability, producing faster and stronger cardiac activity. In smooth muscle, however, pKa inhibits myosin light chain kinase. Without adequate myosin phosphorylation, smooth muscle relaxes. So this explains why beta-1 stimulation increases cardiac contraction while beta-2 stimulation produces bronchodilation and vasodilation. The high-yield principle is that a second messenger does not have a one universal physiological effect. Always identify the receptor, the tissue containing it, and the downstream proteins present in that tissue. So autonomic drugs can either imitate or block cholinergic and sympathetic signaling. Cholimimetics activate muscarinic or nicotinic receptors directly or indirectly increase acetylcholine by inhibiting acetylcholinesterase. Cholinereceptor blockers antagonize these receptors, so muscarinic blockers are commonly called parasympatholytics. Sympathomimetics activate alpha or beta receptors, increasing catecholamine release or prevent catecholamine reuptake. Sympatholytics reduce sympathetic effects, often by blocking alpha or beta receptors. So to predict an autonomic drug's action, use a consistent sequence. Identify the receptor, locate the organ, recall the receptor's normal effect, and determine whether the drug activates or blocks it. And then add any baroreceptor compensation. This prevents memorizing each drug as an isolated collection of effects. Right, so we have made it to the drug boogaloo of this all, okay? Right before our pediatric closure here, okay? So we're about to dive into some cholinergic drugs. All right, and we'll get into androgenics later, but I separated them by cholinergic and then androgenic. So with that said, cholinergic agonism can involve muscarinic receptors, nicotinic receptors, or both. Muscarinic stimulation generally produces rest and digest effects, meiosis, near accommodation, increased salivation and lacrimation, bronchoconstriction, bradycardia, increased gastrointestinal activity, and detrusor contraction, promoting urination. Remember that sweating is also muscarinic, even though sweat glands receive sympathetic innervation. Nicotinic stimulation activates autonomic ganglia or the neuromuscular junction, so its effects depend on the receptor subtype and location. Acetylcholinesterase inhibitors increase acetylcholine everywhere they are released, or it is released, acetylcholine that is, stimulating both muscarinic and nicotinic receptors. And muscarinic blockade produces the functional opposite, so mydriasis, dry mouth, bronchodilation, tachycardia, constipation, and urinary retention. Predict the organ effect before memorizing the drug, and you should be okay. And so the way we're going to go about these, I am going to give you the textbook definition of all these things, and then I will give you my monkey mode way to memorize these. We all love monkey mode here at MooseMed, okay? So fret not, I'll give you a fun, kind of silly way to memorize these. I don't have a little something for all of them, but for the most part, I do have a little something for the big ones. All right, so I'll touch on the funny pictures at the very end, so don't worry. That's part of the monkey mode brain, if you couldn't already tell. But with that said, let's just jump right in. So acetylcholine activates both muscarinic and nicotinic receptors, but it's hydrolyzed so rapidly that it has limited clinical usefulness. Bethenacol is more clinically important because it selectively stimulates muscarinic receptors, especially in GI and urinary systems. It contrasts the detrusor and increases GI motility, making it useful for non-obstructive urinary retention or selected cases of neurogenic bladder. The safety word is non-obstructive here, okay? Stimulating contraction against a physical obstruction could cause harm. Methacholine is a potent muscarinic agonist that produces bronchoconstriction. It is used in a controlled bronchial challenge test when airway hyperreactivity is suspended. So a useful association is bethenacol for the bladder and methacholine for the methacholine challenge. Okay, now breaking down these silly little images. So for acetylcholine, I have this disintegrating baby, and that's because the important thing to remember about acetylcholine is that it's rapidly hydrolyzed, so it's extremely short acting. Okay, so I just remember like the big thing about acetylcholine, aside from it being a non-selective muscarinic and nicotinic agonist, right? It just acts everywhere. It's rapidly hydrolyzed. Okay. Bethenacol, I just remember as the poop one. Okay. So again, we're dealing with muscarinic agonists here. So I just remember that it's parasympathetic, and remember parasympathetics rest and digest. Digest also means pooping, right? So bethenacol, I just remember as the poop one. But muscarinic selective agonist. There you go. Methacholine, I like to remember as a sketchy guy. This is actually the traitor from Resident Evil. And when you see him, he talks in a voice like this. And when you know, if you were to turn down a random alley and see someone talking like this, you would kind of become short of breath, right? So with methacholine, I just remember meth, even though we are covering meth later. But I just remember methacholine. If I saw a guy dealing methacholine like this, I'd go, and my lungs would bronchoconstrict. So I just remember you could either use the challenge to remember this one or use my dumb little my brain activity to remember this, because this is just what goes on through my brain when I see these drugs. So moving on. All right, so pilocarpine and cevimeline. So pilocarpine and cevimeline are direct muscarinic agonists as well, and they are especially useful for increasing glandular secretions. So pilocarpine also has important ocular effects. So it contracts the iris sphincter, producing meiosis, and contracts the ciliary muscle, which facilitates aqueous humor outflow through the trabecular pathway. So it can therefore be used in glaucoma and to produce meiosis during certain ophthalmic procedures. Systemically, it can treat xerostomia. And then cevimeline is relatively selective for M3 receptors and primarily increases salivary secretion, making it useful for dry mouth associations with Sjögren's syndrome or salivary gland damage. Because both drugs enhance muscarinic signaling, predictable adverse effects include sweating, nausea, visual blurring, increased secretions, and potential bronchoconstriction. And so the way I like to remember these is pilocarpine. I like to remember this image of Rick from Rick and Morty fame and him drooling with those tiny pupils. Okay, so the drool lets you remember that, you know, its clinical use for xerostomia. And then the pinprick pupils can help you remember that meiosis effect. Okay, whereas cevimeline, okay, I have this disgusting Patrick Star picture because it has a ton of spit in it, and that's what I want you to think about when you see cevimeline. I just see cevimeline, I go cevimeline spit, you know, and so that will help you remember that it's an M3 selective agonist. Okay, so the big thing with that one is it just increases salivary secretion, which again with pilocarpine it does that as well, but it also has that eye effect. All right, so varenicline is a partial agonist at neuronal alpha-4 beta-2 nicotinic acetylcholine receptors. And that is a mouthful, but thankfully it's the only one, at least for our program, that we need to memorize that is an alpha-4 beta-2 nicotinic acetylcholine receptor, so you can remember it in that regard. Its partial agonist behavior explains both parts of its clinical action. So in the absence of nicotine, it provides moderate receptor stimulation and sustained mesolimbic dopamine release, reducing craving and withdrawal symptoms. So if nicotine is present, though, varenicline occupies the receptor but produces less activation than nicotine, so it reduces nicotine's rewarding effect. It therefore acts like a weak agonist by itself and functionally an antagonist in the presence of the full agonist being nicotine. Varenicline is used for smoking cessation and works best as part of a broader cessation plan. So common adverse effects include nausea, insomnia, headache, and vivid abnormal dreams. Remember that its targets are nicotinic. Okay, and that's kind of easy to remember here with the smoking cessation, but that's why we have the no smoking here. I just remember varenicline as the one that smokers use. All right, and again, special with that alpha-4 beta-2 nicotinic receptor. All right, staying in this cholinergic space, right? We're using acetylcholine still. We're just going to shift our we're going to shift our attention to a different type of cholinergic type drug, which is acetylcholinesterase inhibitors. And it's exactly what it sounds like. You are breaking the enzyme that kills acetylcholine. So if you kill the killer, you have more acetylcholine hanging out in the synaptic cleft, right? So because acetylcholine is used at muscarinic receptors, autonomic ganglia, and neuromuscular junctions, these drugs enhance both muscarinic and nicotinic signaling. Their distribution depends strongly on chemical structure. So quaternary permanently charged agents such as neostigmine, pyridostigmine, and edrophonium penetrate the blood-brain barrier extremely poorly because they're charged. So their effects are predominantly peripheral. Lipid-soluble tertiary agents such as physostigmine and donepezil or donepezil can enter the CNS, right? So muscarinic effects include secretions, bronchoconstriction, bradycardia, and diarrhea. At the neuromuscular junction, moderate acetylcholine elevation can improve transmission, but excessive stimulation produces depolarization, receptor desensitization, weakness, and potential paralysis. Right, so now we're getting into our acetylcholinesterase inhibitor drugs to know, and we just talked about them a little bit in the past slide, but now the deep dive. So neostigmine is a peripheral acetylcholinesterase inhibitor used for myasthenia gravis and reversal of non-depolarizing neuromuscular blockade. During blockade reversal, it is paired with atropine or glycopyrrolate to prevent unwanted muscarinic effects such as bradycardia and secretions. Pyridostigmine lasts longer and is commonly associated with long-term treatment of myasthenia gravis. It also has been used as a pre-treatment when nerve agent exposure is anticipated. Edrophonium is extremely short-acting and is the classic historical association with diagnostic testing for myasthenia gravis. Donepezil crosses the blood-brain barrier and increases central cholinergic signaling in Alzheimer's disease. Physostigmine also enters the CNS, making it useful for severe central and peripheral antimuscarinic toxicity when appropriately indicated. So, the way I like to remember these is, neostigmine, pyridostigmine, and physostigmine are all kind of derivatives of each other. And so is edrophonium, but I have a better way to remember that one, so I'm kind of leaving it out here. So neostigmine, I just remember as the catch-all, the good one, right? That this is used to cure myasthenia gravis, or treat it rather, and it reverses that non-depolarizing neuromuscular blockade. So it's just the basic one. So it's Charmander. It's our stage 1 Pokemon, right? Pyridostigmine, it's a little bit longer, okay? Longer acting than neostigmine, right? So it's a little bit more complicated, right? So it's going to be the second stage, which is Charmeleon, okay? And same thing, right? Used in myasthenia gravis and that reversal of the blockade, okay? And then we have physostigmine, which I like to remember as Charizard, right? The biggest one, and he's like the coolest one because he can enter your central nervous system, right? He can cross that blood-brain barrier because he's him. He's the stage 3. Now, edrophonium is also acetylcholinesterase inhibitor, but I like to remember this one in a slightly different way. So I like to remember that it's also charged because edrophonium, your phone, needs to be charged. So there you go. And then the E at the beginning, I like to read as like edrophonium, because if someone asks you, hey, did you take the edrophonium test to see if you had myasthenia gravis? And you go, I'm still waiting on the results. So that's how I remember that one, that it's used to test for myasthenia gravis. I'm still waiting on my results. Donepezil, I initially for the longest time pronounced it donepezil, and by the longest time I literally mean like an hour ago before I looked up the pronunciation when recording this video. But I always remember this one because when you're gonepezil, you take donepezil, and by gonepezil I mean you have Alzheimer's or dementia. So you take donepezil or donepezil, and that will increase your acetylcholine and thus increase your awareness, maybe get rid of some delirium. So there you go. That's how I remember those. So, your Charmander, your Charmeleon, your Charizard, the edrophonium, and then when you're gonepezil, you take donepezil. All right, so cholinergic toxicity produces muscarinic, nicotinic, and sometimes central nervous system findings. So muscarinic symptoms are best memorized with this sludge mnemonic, which is salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis, which is puking. The immediately dangerous findings are what's called the killer bees, which are bradycardia, bronchorrhea, and bronchospasm. So nicotinic overstimulation causes fasciculations, followed by weakness and paralysis, including respiratory muscle failure. And so lipid-soluble or organophosphates may also cause confusion and seizures. So management begins with decontamination and aggressive airway and respiratory support. Atropine blocks muscarinic receptors and is titrated primarily to control bronchial secretions and bronchospasm. Pralidoxamine can reactivate acetylcholinesterase in organophosphate poisoning if administered before enzyme aging, which we'll get into in the following slides, so don't worry about it. And this helps particularly with nicotinic weakness. So benzodiazepines are just kind of broadly they're going to be used for seizures. But like I said, we'll get into this later. This is just mainly for the sludge mnemonic and those killer bees. So atropine versus pralidoxamine. So in organophosphate poisoning, atropine and pralidoxamine solve different problems. So atropine completely blocks muscarinic receptors, rapidly treating the life-threatening muscarinic findings of bronchorrhea, bronchospasm, bradycardia, and excessive secretions. So it is repeatedly dosed until pulmonary secretions and bronchospasm improve, not simply until the heart rate normalizes. So, however, atropine does not restore acetylcholinesterases and does not directly reverse nicotinic skeletal muscle weakness. Pralidoxamine, or 2-PAM, reverse the organophosphate from acetylcholinesterase and may improve neuromuscular weakness. It must be administered early before the phosphorylated enzyme undergoes what's called aging, after which reactivation becomes ineffective. Because pralidoxamine poorly enters the central nervous system, benzodiazepines may also be needed for the seizures. So remember that atropine protects the organs, whereas pralidoxamine regenerates the enzyme. The way I like to remember these guys too is that with some of the drugs, it's fun to look back into the history, and atropine actually comes from a berry that was used by Cleopatra. And she would take these little berries to dilate her pupils to become more attractive, or to, I guess, be perceived as more attractive. Just a fun little way to remember atropine there. But I just remember that one is a anti-muscarinic because it's going to make your pupils big, right? So there you go. And then with pralidoxamine, I remember as a crowbar because it's going to pry off that organophosphate off of the acetylcholinesterase to then restore it. So I just remember that one's used with organophosphate poisoning because of its ability to pry off an organophosphate, aka pralidoxamine. So there you go. All right, so now comparing atropine and glycopyrrolate. So atropine and glycopyrrolate are both muscarinic antagonists, like we said with atropine, but their distribution differs here. So atropine, like I said, is a tertiary amine that crosses lipid membranes and the blood-brain barrier, and this makes it useful for cholinergic poisoning, symptomatic bradycardia, and ophthalmic mydriasis, and cycloplegia, which just means your eyes are no longer able to accommodate. But it also creates a risk of agitation, confusion, and other central toxicity. So its ocular effects can last for days, as we said with Cleopatra. Okay. Glycopyrrolate is a permanently charged quaternary compound, so it has minimal central nervous system penetration. It is useful when we want peripheral anti-muscarinic effects, such as reducing respiratory or GI secretions. It is also paired with neostigmine during reversal of non-depolarizing neuromuscular blockade. So both can cause dry mouth, tachycardia, constipation, urinary retention, mydriasis, and blurred vision, pretty much all the things that you can come to expect with anti-muscarinics. With glycopyrrolate, I already gave you guys the Cleopatra way to remember atropine, but with glycopyrrolate, I like to remember this guy is an anti-muscarinic, but I just remember the G in glycopyrrolate, same thing, that, G for gut as well, so I just remember that this one is mainly used for that reduced GI and respiratory secretions there, so I just remember the GI association with glycopyrrolate there. So there you go. Now we're getting into respiratory antimuscarinics. So ipratropium and tiotropium are inhaled muscarinic antagonists that block vaguely mediated bronchoconstriction, producing bronchodilation and reducing airway secretions. Their quaternary ammonium structures limit systemic absorption and central nervous system penetration, allowing most of the effect to remain in the lungs. The major difference is duration here. So ipratropium is shorter acting and is often used for acute symptom relief, including in combination with a short-acting beta-2 agonist during COPD exacerbations. Tiotropium dissociates more slowly from airway muscarinic receptors and provides prolonged bronchodilation, making it primarily a once-daily maintenance medication. These agents are especially important in COPD and may also be used in select asthma patients. Local delivery reduces systemic toxicity, although dry mouth and throat irritation may still occur. So just remember that ipratropium is shorter and tiotropium is longer, and you should be good. The way I like to remember these is the reason I have the Buzz Lightyear here is because I was really struggling to memorize these drugs on my first pass here. But then when I just started to remember that the tropiums are basically, if you know the word trope, it just means something that commonly happens or is a common thing in movies. Like a common trope is the little child being like a vessel for some demon, right? Like the come play with us, that sort of thing. That's a trope. So I just remember that the tropes are basically just albuterol. They're literally just albuterol. They're literally just the same thing, but the difference is how they do that bronchodilation. Okay, so albuterol does it through beta-2 agonism, right, with that bronchodilation, whereas these are muscarinics. They're anti-muscarinics. Okay, so they're anti-bronchoconstriction. Okay, so they're both doing bronchodilation just from different angles. So that's why I have the Buzz Lightyear here to remind you that this is literally, don't get tripped up by the fancy spelling. This is literally just an inhaler. This is literally like albuterol, right? And then I have the uncle here just to remind you that tiotropium is the longer acting one between the two of these here, because tio means uncle in Spanish. So tio, I just remember uncle. They're usually older, right? And if you're older, then you're longer lasting than a younger person. So there you go. But that's just how I remember those. So first, that Buzz Lightyear to ground yourself. Just remember it's literally just like albuterol, but muscarinic, okay? And then you got the uncle to help you out there. Right, and now we have the overactive bladder drugs, okay? And these are also antimuscarinics. These are all antimuscarinics, and I'll let you know when we do the switch. So during normal urination, parasympathetic M3 stimulation contracts the detrusor muscle, okay? So therefore, blocking M3 receptors relaxes the bladder and increases its storage capacity. Oxybutynin is an antimuscarinic drug with functional M3 blockade that reduces urinary urgency, frequency, and urge incontinence. Transdermal delivery may reduce some systemic adverse effects compared with oral dosing. Darafenicin is more M3 selective and is used for the same general purpose. The predictable adverse effects reflect muscarinic blockade elsewhere, so dry mouth and eyes, constipation, blurred vision, dizziness, and urinary retention. These drugs should be used cautiously when bladder outflow is already impaired because they can increase post-void residual volume. In older adults, also consider the patient's total anticholinergic burden, since cumulative exposure is associated with confusion, cognitive impairment, falls, and possibly increased dementia risk. And this is especially important if you're going into geriatrics, right? I mean, anything that's anti-muscarinic, especially with patients with dementia, it's important that their acetylcholine receptors are active and available, right? Because acetylcholine helps with that cognition. So if you're putting them on a lot of anti-muscarinics, you're blocking a lot of what acetylcholine could be doing. So very, very high risk there for the elderly population. Outside of that, though, the way I like to remember these monkey mode, okay, I like to remember the scene from Star Wars. So Darfenicin is Darth Vader, and he's telling to Luke, he's saying, "Luke, I am your father." And Luke's like, no, it can't be possible. Okay, but literally the brain way to remember this is just that they're related, okay? They both serve the same purpose, which is hold in your pee, and you would never catch Darth Vader pissing himself, okay? So he retains all that fluid. So you can just remember that Darfenicin has oxybutynin as a son, okay? And just remember that they're both antimuscarinics to both serve the same purpose of not making you pee yourself. So there you go. Right, so now we have our central nervous system and eye antimuscarinics, and these are just the most direct ones. I know the ones that we've talked about previously also involve the central nervous system and eyes in some shape or form, but these are the most direct. Okay, so these drugs illustrate how tissue penetration and duration determine clinical use. So benztropine is a tertiary antimuscarinic that enters the central nervous system and may reduce tremor and rigidity in Parkinson's disease or medication-induced Parkinsonism. It is less helpful for bradykinesia and is generally avoided in older patients because of cognitive adverse effects, like I said, with all these antimuscarinics. Scopolamine also penetrates the central nervous system and is commonly delivered by transdermal patch for motion sickness, but it can cause drowsiness, dizziness, agitation, or confusion. Tropicanamide is a short-acting ophthalmic antagonist used to produce mydriasis and cycloplegia during an eye examination. Its effects last hours rather than the prolonged effects of atropine. So a major warning is the angle closure for angle closure glaucoma. So antimuscarinic mydriasis can narrow the anterior chamber angle, and this will impair aqueous humor drainage and acutely raise intraocular pressure. Okay, so the way I like to remember these ones. So benztropine, like a Mercedes-Benz, but who's driving that Benz? Dopamine is. And the way I remember this is because benztropine is used with dopamine to help alleviate Parkinson's disease, right? So I just remember benztropine is dopamine driving a Benz, okay? Scopolamine, the way I remember this is used for motion sickness is because when I first heard scopolamine, I thought of like a police guy, like scoping out a scene or doing a stakeout. So if you're scoping out a crime in a car, you don't want to get car sick while you're scoping out a crime scene, so you take scopolamine. Tropicanamide, I just remembered because of the orange juice, Tropicana, and when you see orange juice, I don't know about you guys, but sometimes I go for a long time without having orange juice, right? And, because it kind of gets old, but then, when you've gone, that 3-month period of not having a glass of orange juice, and then you have that first glass of ice-cold orange juice, my God, it is it's like the elixir of the heavens. It is so good. So when you see Tropicana, your eyes go really big. You go, orange juice, right? So tropicanamide, that's how I remember that this is the one that's used for eye exams, okay? And if you've ever gotten your eyes checked, right, and you wear those big goofy glasses for such a long time, it's hard to forget that. So anyway, tropicanamide, there you go. All right, so now we're moving on to mecalamine and ganglion blockade here. So mecalamine is kind of in a class of its own just because it's pretty special. And here's why. So it blocks neuronal nicotinic receptors in both sympathetic and parasympathetic autonomic ganglia. Because it removes both divisions simultaneously, its effects on organs depend on which division normally provides the dominant resting tone. So most blood vessels are under sympathetic tone, so ganglionic blockade causes vasodilation and potentially severe orthostatic hypotension. The resting heart is predominantly under parasympathetic influence, so removing vagal tone causes tachycardia. Blocking parasympathetic control of the eye, gastrointestinal tract, bladder, and salivary glands produces mydriasis, cycloplegia, constipation, urinary retention, and dry mouth. Sweating also decreases because sympathetic fibers to sweat glands still depend on nicotinic transmission into the ganglion. This widespread loss of coordinated autonomic regulation explains why ganglion blockers are rarely used for clinically. So the exam strategy is always to identify each organ's dominant baseline tone with this guy. So I just remember mecalamine. There's this great video game that recently came out called Dispatch, where the main character is this guy named Mecha Man, all right? And you can see Mecha Man standing there in a very, very epic position there, and he has his 2 controllers for his mecha suit, all right? And each controller is for each side of your autonomic nervous system. And that's just how I remember mecalamine does both sympathetic and parasympathetic blockade of nicotinic receptors, okay? So the key with this guy, honestly, the way he'll probably get tested is they're going to hyperfixate on a certain organ, and you got to tie in your knowledge of the resting tone of that organ, and then what mecalamine would do to it. So there you go. All right, so now we're going to switch from muscarinic side of things to the adrenergic side of things. So this means that we're using norepinephrine, alpha receptors, beta receptors, right? So to predict an adrenergic agonist's effect, you want to begin with the receptor profile, right? So let's do a quick recap. So alpha-1 activation contrasts vascular smooth muscle, increasing systemic vascular resistance and blood pressure. It also causes mydriasis and contracts urinary and GI sphincters. Alpha-2 activation reduces sympathetic output centrally and decreases presynaptic norepinephrine release through negative feedback. Beta-1 stimulation increases heart rate contractility, AV node conduction, and renin release. Beta-2 stimulation relaxes smooth muscle, producing bronchodilation, skeletal muscle vasodilation, and uterine relaxation. Dopamine D1 receptors dilate renal and splanchnic vessels, although dopamine loses receptor selectivity as as its dose increases, and we'll get into that later. That dose dependence is an important point there, but like I said, we'll talk about it a little bit later. So after determining the direct receptor effects, always add the baroreceptor reflex, right? We can't forget about that baroreceptor reflex. So again, a major rise in pressure can reduce heart rate, while vasodilation and falling pressure can provoke reflex tachycardia. All right, so let's get into direct and indirect androgenic agonists, right? So direct agonists are going to bind that androgenic or dopamine receptors to themselves, so their effects are determined mainly by receptor selectivity and dose. So phenylephrine directly it activates alpha-1 receptors, while dobutamine primarily stimulates beta-1 receptors. Indirect agonists do not need to bind the postsynaptic receptor. Instead, they increase norepinephrine within the synaptic cleft by releasing stored transmitter, reversing the norepinephrine transporter, or blocking reuptake. Amphetamine and tyramine promote norepinephrine release, while cocaine blocks net-mediated reuptake. Mixed acting drugs such as ephedrine both stimulate receptors and increase transmitter release. So this distinction predicts what happens when neuronal norepinephrine stores are depleted. Okay. So indirect agents may also show tachyphylaxis as available transmitter stores decline. Okay, so that's something to keep in mind when looking at vignettes. So again, this is just a big map, all right? And then now we're just going to get into each drug on their own, all right? So here we go. All right, so phenylephrine is a relatively selective alpha-1 agonist, and its direct effect is going to be constriction of the arteriolar and venous smooth muscle, so which is all going to increase systemic vascular resistance and raise systolic, diastolic, and mean arterial pressure. So this increased pressure activates baroreceptors, which is going to increase vagal activity and produce reflex bradycardia. Therefore, even though phenylephrine is a sympathomimetic drug, the observed heart rate may fall. So atropine can block this vagally mediated slowing, revealing that it is a reflex rather than a direct cardiac effect. Phenylephrine also contracts the iris radial muscle, causing mydriasis without cycloplegia because it does not paralyze the muscarinic controlled ciliary muscle. But its clinical use includes raising blood pressure during acute hypotension or anesthesia, nasal decongestion, and producing mydriasis. So just remember that phenylephrine squeezes vessels, raises blood pressure, and reflexively slows the pulse. I like to remember phenylephrine by this little picture at the bottom right from SpongeBob when Patrick wants to help out our boy Squidward when he's in a full body cast and wants to brighten up his day by taking him jellyfishing. So he gives him a net, but since he's in a full body cast, he can't grasp it. So he shoves it right in his hand and he goes, firmly grasp it. And that's how I think of phenylephrine. I think of it as a vasoconstrictor. So whenever I say it, I go phenylephrine, and that little fring reminds me that it's tightened up. It's tightened up, I imagine it, if it was a little character, it would just have a super tight corset on that it would tighten, right? So like phenylephrine, right? So there you go. Now you won't forget it. Sounds goofy, but it's stuck in your head now. So there you go. All right, so norepinephrine activates alpha-1, alpha-2, and beta-1 receptors with very little clinically meaningful beta-2 activity. So alpha-1 vasoconstriction, as we all know, markedly increases systemic vascular resistance and raises both systolic and diastolic pressure. Beta-1 activation directly increases cardiac contractility and would tend to increase heart rate. However, the large rise in mean arterial pressure activates the baroreceptor reflex, producing enough vagal activity that the net heart rate effect is commonly bradycardia. Thus, norepinephrine increases contractile force while the pulse may decrease. It is important vasopressor for severe hypotension and distributive shock, particularly septic shock. A major exam distinction is that norepinephrine cannot replace epinephrine in anaphylaxis. So it can support blood pressure, but its minimal beta-2 activity does not provide the necessary bronchodilation or help suppress mediator release as effectively as epinephrine. So norepinephrine's fairly easy, but if you need help, right? I think of this show called H2O, Just Add Water, an Australian show about mermaids. And there's a character named Claire, and if you've seen the meme, you know where I'm going with this. So there's a scene where Claire's doing something. I don't know, I haven't seen the show, but she's doing something, and her friends don't like it that much. And since they're all Australian, they all talk funny. So they see Claire and they go, Claire, nor, and that's how I remember norepinephrine, because nor beta-2 receptor, as in it has a weak beta 2 response. So you can just remember norepinephrine because it does pretty much all of them, but it has a really shitty beta 2 response, so it's not used for that, okay? So it's just a worse epinephrine, which is our next slide. But like I said, clear nor beta 2 receptor. So there you go. All right, so epinephrine. So epinephrine activates essentially the entire adrenergic system, so allowing it to support the heart, blood vessels, and lungs at the same time. So again, beta 1 stimulation increases heart rate, contractile force, while beta 2 stimulation relaxes bronchial smooth muscle and dilates vessels supplying skeletal muscle. Alpha 1 stimulation produces vasoconstriction, which raises blood pressure and reduces tissue swelling. And these combined actions explain why intramuscular epinephrine is the first-line treatment for anaphylaxis. It opens up the airway, limits mucosal edema, restores vascular tone, supports cardiac output, and reduces further mediator release from mast cells. The same broad receptor activity makes epinephrine useful during cardiac arrest and severe shock. When it's combined with a local anesthetic, alpha 1 mediated vasoconstriction keeps the anesthetic near the injection site, slowing systemic absorption and prolonging its effect. Epinephrine also increases circulating glucose and fatty acids, providing readily available fuel during the sympathetic fight or flight response. And I just like to remember this one because, if anyone's ever having an anaphylactic shock, you use their EpiPen, right? So that's why we have the dog stung by a bee here, to just remind you that this has to do with severe allergic reactions, so anaphylaxis. And then the big Giga Chad guy, because this guy, epinephrine just does all the androgenic receptors. So it's just him. It does all of them. It does all of them. So there you go. All right, so the cardiovascular response to epinephrine depends on which receptor is dominant at that given concentration. So at lower concentrations, beta receptors are more sensitive. So beta 2 vasodilation decreases systemic vascular resistance and diastolic pressure. At the same time, beta 1 stimulation increases cardiac output and systolic pressure. So this can widen the pulse pressure while leaving mean arterial pressure unchanged or slightly decreased. As the dose rises, alpha 1 vasoconstriction becomes increasingly important and begins to counteract beta 2 vasodilation. At high concentration, widespread vasoconstriction raises systemic vascular resistance and mean arterial pressure, and beta 1 stimulation is still trying to accelerate the heart, but the rise in arterial pressure activates the baroreceptor reflex and increases vagal output, thus decreasing heart rate. So the observed heart rate therefore reflects competition between direct beta 1 tachycardia and reflex bradycardia. So a useful way to approach exam questions is to remember that systolic pressure largely follows cardiac output, so whereas diastolic pressure largely follows systemic vascular resistance. Clonidine. So clonidine is an alpha 2 agonist, okay? But its clinically important action occurs centrally rather than through direct stimulation of peripheral blood vessels. So activating alpha 2 receptors in the brainstem reduces sympathetic signaling to the heart and vasculature, so with less norepinephrine reaching peripheral androgenic receptors, heart rate, cardiac output, vascular tone, and blood pressure decrease. This central sympatholytic effect explains clonidine's use in hypertension and in withdrawal states, where it helps to control autonomic symptoms such as sweating, tachycardia, and elevated blood pressure. Reduced sympathetic activity also accounts for adverse effects such as orthostatic hypotension, sedation, and dry mouth. The major warning is that clonidine should not be stopped abruptly. During chronic treatment, the androgenic system adapts to persistently reduced sympathetic signaling. Sudden removal can expose this sensitized system to a surge of catecholamine activity, producing tachycardia and potentially severe rebound hypertension. Clonidine, therefore, is to be tapered rather than to be discontinued suddenly. And I like to remember this one because alpha 2 you already remember as just the sympathetic brake. So clonidine just presses on that brake. It just activates alpha 2. So if you, honestly, if you just remember clonidine as the alpha 2 effect, you'll be fine. All right, so dobutamine and albuterol illustrate how receptor selectivity directs a sympathetic drug towards a particular organ. So dobutamine acts predominantly as a beta 1 receptor in the heart, increasing contractile force and stroke volume, and its main purpose is therefore to improve cardiac output in patients with impaired pump function, so such as acute heart failure or cardiogenic shock. Because stronger and faster cardiac activity increases oxygen consumption, dobutamine can provoke tachyarrhythmias or worsen myocardial ischemia. Albuterol instead favors beta 2 receptors in bronchial smooth muscle. Through a GS-CAMP clamp pathway. It relaxes constricted airways and provides rapid release during acute bronchospasm. So inhaled, administered concentrates the drug in the lungs. So although selectivity is not absolute here, because you'll get some vasodilation. So systemic beta stimulation can produce tremor, palpitations, anxiety, and hyperglycemia. So beta-2 activity also stimulates the sodium-potassium pump, shifting potassium into cells and potentially causing transient hypokalemia. But the simplest distinction is that dobutamine involves the pump, whereas albuterol opens the airway. And so dobutamine I like to remember as the bomb. It is the bomb with getting your heart rate up. Like if you ever had a little bit of spicy sauce, your heart rate starts to go up. You're like, oh my god, okay, this is really spicy, right? So dobutamine I just remember as the bomb. For all my Hot Ones fans out there, shout out Sean Evans, the GOAT, love that guy. Then we got albuterol. Albuterol, like I said, this one's pretty easy to remember because it's inhalers, right, guys? So I don't know, beta-2, albuterol. There you go. So isoproterenol and phenoldiprem. So isoproterenol stimulates beta-1 and beta-2 receptors without meaningful alpha activity. So beta-1 stimulation, like I said, it's going to increase that heart rate and contractility, while beta-2 stimulation is going to cause that vasodilation and bronchodilation. Because systemic vascular resistance falls, diastolic pressure decreases, and the baroreceptor reflex produces additional tachycardia on top of the direct beta-1 effect. And this makes isoproterenol especially likely to cause rapid heart rate arrhythmias, angina, and flushing. So its clinical use is now limited, but it may occasionally be used for severe bradycardia or heart block. Phenoldiprem works through an entirely different receptor as peripheral dopamine 1 agonist. It dilates systemic renal arterioles, lowers vascular resistance, and promotes renal sodium excretion. Its rapid onset and very short duration allows blood pressure to be adjusted through continuous intravenous infusion, making it useful in hypertensive emergencies. So vasodilation can produce headache, flushing, and reflex tachycardia. Phenoldiprem can also increase intraocular pressure, so it should be avoided or used cautiously in patients with glaucoma. And the way I like to remember these is that isoproterenol, right? I just remember isoproterenol, and that reminds me that it's beta-1 and beta-2 that it is an agonist for. Whereas phenoldiprem, it's the only D1 agonist that my program needs to remember, so it's kind of easy to remember in that regard. But aside from it being the only D1 agonist that I need to know, the other big thing is that it causes natriuresis, so you're going to be peeing out a lot of sodium, right? So if you're losing a lot of sodium, water's going to follow, so you're going to be peeing a lot. So that's how I remember the loss of sodium and thus peeing. And I don't know, I just a lot of like dilation, peeing. It kind of triggers that memory line for me, and then I remember what phenoldiprem does. But just remembering that it's the one D1 agonist that at least I need to know, it's pretty easy. All right, so dopamine is traditionally taught as progressing through different receptor effects as its infusion rate increases. So at low doses, dopamine receptor stimulation produces renal and mesenteric vasodilation. At intermediate doses, beta-1 activity becomes more predominant, increasing contractility, heart rate, and cardiac output. At high doses, alpha-1 mediated vasoconstriction dominates and raises systemic vascular resistance and blood pressure. So this sequence can be just remembered by going in reverse alphabetical order. Okay, so it goes D, B, and then A. All right, so not much more to say there. So just knowing what each of those receptors do. And other than that, there you go. All right, so next we have amphetamine and ephedrine. Okay, so amphetamine is an indirect sympathomimetic because it increases catecholamine signaling primarily through releasing neurotransmitters rather than directly stimulating the adrenergic receptors. So it enters the presynaptic neuron through monoamine transporters and then enters storage vesicles through VMAT. This displaces norepinephrine and dopamine into the cytoplasm, allowing the transporters to run in reverse and release these monoamines into the synapse. Because amphetamine readily reaches the central nervous system, it produces prominent central effects that contribute to its therapeutic use in ADHD, as well as its potential for misuse. So repeated exposure can reduce the available vesicular neurotransmitter and contribute to tolerance or tachyphylaxis. Okay, so amphetamine, this is the same as methamphetamine, okay, which is what the abuse is alluding to there. Okay, Ephedrine has mixed action. It directly stimulates alpha and beta receptors while also causing norepinephrine release from sympathetic nerve terminals. So the result is increased cardiac output, vascular tone, and blood pressure, making it useful for hypotension associated with anesthesia. Because part of its action depends on stored norepinephrine, repeated doses may become progressively less effective as those stores are depleted. So ephedrine can enter the central nervous system, although its central effects are less pronounced than those of amphetamine. Okay, so we have a lovely, lovely, lovely picture of Violet from The Incredibles, and I think this scene is specifically from Incredibles too, but it's such a great depiction of reversing reversing that norepinephrine uptake, right? So it's shooting it out through the presynaptic neuron instead of keeping it stored up in there. So it basically just makes the presynaptic neuron spew it all out. So there you go. That's how I remember the effects of amphetamine and ephedrine. And again, just remember that amphetamine has no sort of receptor activity itself. It just simply reverses norepinephrine, whereas ephedrine does that as well as activating those androgenic receptors, but weakly. All right, so tyramine and cocaine. So tyramine is an indirect sympathomimetic found in aged and fermented foods. Under normal conditions, monoamine oxidase in the intestinal wall and liver metabolizes most tyramine before it reaches the systemic circulation. If monoamine oxidase is inhibited, much more tyramine is absorbed, and it can then enter sympathetic nerve terminals, displace stored norepinephrine, and trigger a sudden catecholamine surge. So the resulting severe vasoconstriction may produce a hypertensive crisis, which is why patients taking non-selective MAO inhibitors must avoid foods containing large amounts of tyramine. Cocaine increases sympathetic signaling by blocking monoamine reuptake, including norepinephrine reuptake through NETs and dopamine reuptake in the central nervous system reward pathways. So norepinephrine, therefore, accumulates around the heart and blood vessels, producing tachycardia, vasoconstriction, and severe hypertension. This combination markedly increases myocardial oxygen demand while reducing coronary blood flow, creating a high risk of myocardial infarction, arrhythmia, and stroke. Cocaine also blocks voltage-gated sodium channels, explaining its limited medical use as a topical local anesthetic. Severe toxicity may also include agitation, seizures, and formication. So that's the sensation of insects crawling on or beneath your skin. So great little advertisement for cocaine there. But a wonderful way to remember these guys. Tyramine, I just remember similar to amphetamine and ephedrine, except it's a little bit of a bitch because it really it only really does anything if you have MAO inhibitors, right? Because MAO normally clears it, so you don't have all those negative effects with foods that contain it. So that's why we have the super fair and definitely not corrupt leader Kim Jong-un staring over tyramine, because as soon as it's done doing its job here, MAO is definitely not going to do anything bad. MAO is definitely not going to do anything bad to tyramine, definitely not, aka it's going to clear it. If you know what I mean. Whereas cocaine here is holding back the nets from clearing up all the norepinephrine. It's like, dude, don't do your job. And the nets are like, please let me take all the norepinephrine, please, it's my job. And cocaine's like, no, bro, trust. You want this in the presynaptic terminal. So anyway, there you go. Here at Moose Med, we have fun ways to remember drugs. All right, so adrenergic blockade. So adrenergic antagonists are easiest to understand as removing the normal function of the receptor being blocked. So blocking beta-1 receptors slows the sinoatrial node, reducing contractility, delays AV node conduction, and decreases renin release from the kidney. Together, these effects reduce cardiac workload, myocardial oxygen demand, and blood pressure. Blocking beta-2 receptors prevents bronchodilation and can therefore provoke bronchospasm. It also interferes with glycogen breakdown and suppresses androgenic warning signs such as tachycardia, making hypoglycemia more difficult to recognize and potentially slower to correct. Alpha-1 blockade relaxes both arterial and venous smooth muscle. Arterial dilation lowers systemic vascular resistance, while venous dilation reduces venous return and preload. These effects lower blood pressure, but can cause orthostatic hypotension. Relaxation of smooth muscle in the prostate and bladder outlet can also explain the use of selective alpha-1 blockers for urinary symptoms associated with benign prostatic hyperplasia. Alpha-2 blockade has the opposite effect of alpha-2 agonism, so it's going to remove that presynaptic negative feedback, allowing more norepinephrine to be released. All right, so keeping that in mind, let's cover some antiandrogenics. Okay, so propranolol blocks both beta-1 and beta-2 receptors. So beta-1 blockade slows the heart rate, reduces contractility, delays AV node conduction, and decreases myocardial oxygen demand. And these actions explain its use in hypertension, angina, selected arrhythmias, and protection after myocardial infarction. Propranolol also enters the central nervous system, which contributes to its usefulness in migraine prevention and in reducing the physical manifestations of essential tremor and hyperthyroidism. Its beta-2 blockade accounts for several important limitations. So preventing bronchial beta-2 stimulation can cause bronchoconstriction, so propranolol is generally avoided in asthma and used cautiously in obstructive lung disease. In patients with diabetes, it can inhibit glycogenolysis and mask warning signs of hypoglycemia, particularly tachycardia and tremor. Excessive beta-1 blockade can worsen bradycardia, AV block, or acutely acutely decompensated heart failure. And then the exam level distinction is that propranolol's non-selective action provides broader therapeutic effects, but it also creates more pulmonary and metabolic risk than a beta-1 selective antagonist. So the way I like to remember propranolol is the pran sounds like pan, and in the pan you have two pieces of bacon with both start with B, so that's your B1 and B2. So I just remember that propranolol blocks both B1 and B2, because if you're cooking bacon, you're frying it up and you're denaturing it, right? So it's blocking B1 and B2. So there you go. Easy way to remember propranolol. All right, so metoprolol is considered cardioselective because it preferentially blocks beta-1 receptors in the heart. This slows the sinus node, decreases contractility, delays AV node conduction, and reduces renin release from the kidney. Together, these effects lower cardiac workload, myocardial oxygen consumption, and blood pressure. This makes metoprolol useful for angina, hypertension, rate control in selected arrhythmias, and protection following myocardial infarction. Extended release metoprolol succinate is one of the beta blockers used to improve outcome in stable chronic heart failure. Cardioselectivity is relative rather than absolute. As the dose increases, metoprolol begins to block beta-2 receptors, so bronchospasm and impaired recovery from hypoglycemia remain possible, although the risks are generally lower than with propranolol. Excessive beta-1 blockade can cause fatigue, hypotension, bradycardia, or AV block. Long-term therapy should not be stopped abruptly because increased beta receptor sensitivity can produce rebound tachycardia, angina, or myocardial ischemia. And the way I like to remember metoprolol is because if you guys have seen the show Invincible, if you haven't, no worries. There's this fight scene where basically the bad guy, who's essentially evil Superman, takes the other superpowered human being and basically holds him in front of a train, and as the train just runs through the guy, everybody in the train just gets shredded because the other superhero is invincible as well. So with that horrible, morbid example, you can remember that if you're in a metro accident, metoprolol, right? It's like metro. If you look at it, it kind of looks like metro. If you're in a metro accident, your heart will stop. So there you go. And that's how you remember that it's a beta-1 selective antagonist, cardioselective. So there you go. All right, so carvedilol combines non-selective beta blockade with alpha-1 blockade. Beta-1 blockade slows the heart and decreases contractility. Beta-2 blockade creates the usual pulmonary and metabolic concerns of a non-selective beta blocker. And alpha-1 blockade dilates arteries and veins. The overall result is a decrease in blood pressure afterload and cardiac workload. This combination is particularly valuable in stable chronic heart failure, where long-term suppression of successive sympathetic stimulation limits adverse cardiac remodeling and improves survival. The important word is stable. So carvedilol is started at low dose and gradually increased in compensated heart failure. It is not initiated during a cardiogenic shock or acute decomposition requiring intravenous inotropic support. So alpha-1 blockade explains the characteristic dizziness and orthostatic hypotension, especially when treatment begins or the dose is increased. Okay, so most beta blockers' adverse effects are predictable extensions of their receptor actions. Too much beta-1 blockade slows the sinus node, delays AV conduction, decreases cardiac output, and can produce bradycardia, heart block, fatigue, or hypotension. Although selected beta blockers improve survival in stable chronic heart failure, starting or rapidly increasing them during acute decompensation decompensation can initially worsen cardiac function. Non-selective drugs also block beta-2-mediated bronchodilation, creating the greatest bronchospasm risk in patients with reactive airway disease. In patients with diabetes, beta blockade can heighten tachycardia and tremors during hypoglycemia. Sweating may still occur because sympathetic innervation of sweat glands is primarily cholinergic, as we've discussed. And non-selective agents can additionally impair glycogenolysis, potentially delaying glucose recovery. Chronic beta blockade increases receptor sensitivity, so abrupt discontinuation exposes a sensitized cardiovascular system to normal catecholamines. The result may be rebound hypertension, tachycardia, angina, arrhythmia, or myocardial infarction. So long-term beta blocker therapy should therefore be tapered gradually. All right, so phentolamine versus phenoxybenzamine. So phentolamine and phenoxybenzamine both block alpha-1 and alpha-2 receptors, but they differ greatly in duration and reversibility. So phentolamine is a competitive antagonist, meaning it binds reversibly and can be displaced when catecholamine concentration rises. So its rapid, short-lived duration makes it useful when temporary control of catecholamine-mediated vasoconstriction is needed, such as an acute phenochromocystoma-related hypertensive episode or local vasopressor extravasation. So its historical diagnostic role has largely been replaced by biochemical testing with plasma or urinary metanephrines. Because phentolamine also blocks presynaptic alpha-2 receptors, norepinephrine release increases. So combined with fall in blood pressure, this can produce a prominent tachycardia. And then phenoxybenzamine binds alpha receptors irreversibly, so increasing the agonist concentration cannot overcome this blockade. Recovery requires synthesis of new receptors, giving the drug a long duration of action, and this makes it useful for sustained preoperative alpha blockade in phenochromocystoma, although orthostatic hypertension and reflex tachycardia can be substantial here. And the easy way to distinguish between the two here is looking at Mr. Napoleon, who was known to be relatively short, but I think historically he's probably not that short. I think there was a little reversal on that opinion there. But anyway, stereotypically, he is short. And so I just remember phentolamine, it just sounds like Napoleon, like phentolamine, and it's a short-acting competitive antagonist, which Napoleon probably was, short and competitive, and he was definitely an antagonist to a lot of countries. Then we got phenoxybenzamine, which, if you just remember that the amines both are alpha antagonists, you can just remember that one is the Napoleon one, and then phenoxybenzamine, which is also just a longer word, you can remember is longer acting there. So there you go. All right, we have just a little clinical correlation with those drugs here. So a phenochromocystoma releases excessive catecholamines, producing episodic or sustained hypertension, along with headaches, palpitations, and sweating. Surgical manipulation can trigger a massive catecholamine release, so androgenic effects must be controlled before the tumor is removed. Alpha blockade is established first to prevent catecholamine-driven vasoconstriction and lower blood pressure. Because chronic vasoconstriction leaves many patients volume depleted, salt and fluid are then replaced to reduce severe preoperative hypotension. So if significant tachycardia persists after adequate alpha blockade, a beta blocker may be added. Giving the beta blocker first is pretty dangerous because blocking beta-2 receptors removes any important vasodilatory pathways with alpha-1 mediated vasoconstriction remaining fully active. So the result is unopposed alpha effect, which can abruptly increase systemic vascular resistance and precipitate to a hypertensive crisis, which will then lead to pulmonary edema, myocardial ischemia, and acute heart failure. The safe sequence is therefore alpha blockade, volume restoration, and then beta blockade only if needed, and finally surgery. All right, so prazosin, dixazin, and tamsulosin selectively block alpha-1 receptors while preserving presynaptic alpha-2 feedback. Blocking vascular alpha-1 receptors prevent arterial and venous constriction, reducing systemic vascular resistance and venous return. Because alpha-2 receptors can still limit norepinephrine release, their selective drugs generally produce less tachycardia than non-selective alpha antagonists. Prazosin and dixazin can lower blood pressure while also relaxing smooth muscle in the prostate and bladder outlets, so they improve urinary flow in patients with benign prostate hyperplasia. Tamsulosin has greater affinity for the alpha-1A receptors concentrated in the prostate and urinary tract. It therefore improves benign prostatic hyperplasia symptoms with less effect on systemic blood pressure, although orthostatic symptoms can still occur. The major class warning is first-dose hypotension, which may cause marked dizziness or syncope after suddenly standing. Therapy is therefore begun at low dose, often near bedtime. Tamsulosin is also associated with intraoperative floppy iris syndrome, so patients should inform their ophthalmologist before cataract surgery. The easy way to remember these guys is they all end in the osin, and I just remember the minions here, and they're yellow, which is the color of urine. So, you can remember that these guys are all helping you pee. And then just alpha-1 antagonism. Alpha-1 is that constriction, so just think like holding in your pee, you're tensing up. Whereas if you're an antagonist to this, which the minions, a lot of people find them annoying, so you can find them antagonistic. It relaxes those blood vessels, and you pee. So there you go. All right, and then we have yohimbe. And yohimbe is a plant extract, while yohimbine is one of the active compounds found in its bark. So yohimbine blocks presynaptic alpha-2 receptors. Normally, these receptors function as a braking system. When norepinephrine accumulates in the synapse, alpha-2 activation limits additional release. So blocking that feedback removes the brake and allows sympathetic neurons to release more norepinephrine. So heart rate, vascular tone, and central arousal can consequently increase. Yohimbe products are commonly marketed for erectile dysfunction, weight loss, or athletic performance, but evidence supporting these uses is quite limited. Supplement preparations are especially problematic because the yohimbine content can vary considerably between products. The Pharmacology predicts the major toxic effects, including anxiety, agitation, tachycardia, hypertension, and arrhythmias. And there are more severe reactions such as seizures and myocardial ischemia, which have also been reported. The high-yield concept is that alpha-2 blockade increases norepinephrine release and producing effects opposite of those of an alpha-2 agonist, such as clonidine, remember, which is our brake. So I remember this guy because of this character Usagi Yojimbo, who is a Teenage Mutant Ninja Turtles spin-off character. But he is a rabbit, and I just imagine samurai yelling with a giant katana. So if they're yelling and screaming with the katana, then their heart rate's up. It's just all sympathetic increase. So, I just like to remember that yohimbe slashes the alpha-2 receptor with his sword, and he's an antagonist. So there you go. All right, so a blood pressure tracing provides information about blood pressure and heart rate at the same time. So each peak represents systolic pressure. So above that line is systolic, and then below the line you're going to have diastolic pressure. And then the horizontal distance between each peak represents the length of one cardiac cycle. So closely spaced peaks therefore indicate a faster heart rate, meaning that mean arterial pressure lies between systolic and diastolic pressure, but it's normally closer to the diastolic value because the heart spends more time in diastole. The baroreceptors respond primarily to changes in arterial stretch. When pressure rises, increased firing from the carotid sinus and aortic arch reaches the brainstem, which then increases parasympathetic activity and suppresses sympathetic activity. The result is reflex bradycardia. When mean pressure falls, reflex tachycardia and increased vascular tone occurs. So for drug questions, first determine the direct receptor effect on heart and vessels, and then decide whether the baroreflex reinforces that direct effect or pushes it in the opposite direction. And man, I had a voice crack there. I need to take some of my tea. Right, so now that was the end of the pharmacy boogaloo. We are now moving into our final topic, pediatrics. Okay, so pediatric medicine requires more than applying adult physiology to a smaller patient. Normal findings change continuously as a child grows, so an isolated observation must be interpreted in the context of age, previous development, and the child's overall trajectory. Growth and development are evaluated over time rather than a single visit. So development is commonly organized into gross motor, fine motor, language and cognitive, and social emotional domains. These domains progress together, but not always at identical rates. The clinician must also adjust the history and examination to child's development level. So information may come from both the patient and caregiver, while play, observation, and age-appropriate language may be more informative than a standard adult interview. Preventive care and anticipatory guidance are central part of pediatrics because many injuries and developmental problems can be identified before they cause lasting harm. Milestone timing varies among healthy children, but loss of a skill that was previously acquired represents developmental regression and should always prompt further evaluation. And then we got our lovely Rugrats welcoming us in to the pediatric section of the video, because man, are we glad to be out of pharmacology. All right, so pediatric age categories provide a framework for anticipating changes in physiology, communication, development, and disease patterns. The newborn period covers the first 28 days of life and is also included within the broader infant period, which extends through the first year. Early childhood begins around 1 year and includes the toddler and preschool years when mobility, language, and independence develop rapidly. Middle childhood roughly corresponds to elementary school years when growth becomes steadier and cognitive and social abilities become more structured. Adolescence then includes the transition from childhood into adulthood and can be divided into early, middle, and late stages. These boundaries are useful conventions rather than rigid biological cutoffs, and exact definitions may differ between organizations. The patient's developmental stage may be more clinically informative than the age label alone. So age nevertheless guides medication dosing, vital sign interpretation, expected milestones, communication style, consent and confidentiality considerations, and the differential diagnosis for common symptoms. All right, so developmental milestones represent skills that most children can perform by a particular age, but they should be interpreted as a progression rather than isolated facts. Social engagement appears early with a social smile around 2 months. By 6 months, infants recognize familiar caregivers and begin producing repetitive constant sounds, or consonant sounds, not constant. But around 9 months, object permanence develops, so the infant understands that a caregiver continues to exist even when out of sight. Crazy how that happens. And this helps explain both peekaboo and the appearance of a stranger or separation anxiety. So around the first birthday, children begin using a few words with meaning. Language expands rapidly during the toddler years. As a useful exam mnemonic, it is that a 2-year-old combines 2 words and a 3-year-old can produce a short 3-word phrase. The traditional intelligibility rule estimates that strangers understand about half of a 2-year-old's speech, 3/4 of a 3-year-old's speech, and nearly all of a 4-year-old's speech. And these are rough bedside guides, not, substitutes for standardized developmental screenings, but it's just good for some quick problems. So failure to acquire expected skills deserves assessment, but loss of a previously acquired skill is especially concerning. Anticipatory guidance tries to prevent injuries before a child reaches the developmental stage that creates the risk. Safe sleep begins with placing an infant supine for every sleep on a firm, flat surface with no pillows, blankets, bumpers, or stuffed objects. Room sharing is recommended, but the infant should have a separate sleep surface. Car seats should remain rear-facing in the back seat until the child reaches the manufacturer's height or weight limit. Safety counseling must change as mobility develops. Once an infant can roll, a bed or changing table becomes a fall risk. So as crawling begins, medications, chemicals, batteries, small objects, cords, stairs, and open water becomes a hazard. Walkers do not teach normal walking and increase the risks of fall. So nutritional guidance includes human milk when available, vitamin D supplementation for breastfed infants, introduction of complementary foods at about 6 months when developmentally ready, and then the avoidance of honey before 12 months because of infant botulism. Toddler counseling shifts towards consistent limits, positive reinforcement, toilet training readiness, and calm management of tantrums. So don't shake your baby. The pediatric vaccine schedule builds protection when children are most vulnerable. Hepatitis B vaccination begins in the newborn period. The primary infant series begins around 2 months. It includes protection against rotavirus, diphtheria, tetanus, pertussis, invasive hemolysis, Haemophilus influenza type B disease, pneumococcal disease, and polio. Influenza vaccination begins at 6 months, while MMR, varicella, and hepatitis A generally begin around the first birthday. Exact timing, catch-up schedules, maternal status, medical records, and newer interventions such as RSV immunizations require consultation of the current schedule rather than relying only on memory. A temperature of at least 38 degrees Celsius or 100.4 degrees Fahrenheit in a neonate requires immediate medical evaluation even if the infant appears well. Young infants may deteriorate rapidly and may show infection through hypothermia, poor feeding, lethargy, irritability, respiratory distress, or poor perfusion instead of just a fever. So the youngest febrile neonates generally require blood, urine, and cerebrospinal fluid evaluation with empiric antimicrobials. Management near the end of the first month may be further risk stratified under current protocols, but fever should never be dismissed or managed expectantly at home. All right, so the APGAR score is a rapid description of how a newborn is transitioning immediately after delivery. The acronym represents appearance, pulse, grimace, activity, and respiratory effort. Each component receives 0, 1, or 2 points, creating a maximum score of 10. Color reflects oxygenation and perfusion. Pulse assesses heart rate. Grimace measures the reflex response to stimulation. Activity represents muscle tone, and respiratory effort evaluates breathing and the strength of a cry. So scores are recorded at 1 and 5 minutes. If 5-minute score remains below 7, assessment is generally repeated every 5 minutes through 20 minutes. The trend is often more informative than a single number because improvement reflects the newborn's transition and response to intervention. Importantly, clinicians don't wait for the 1-minute APGAR score before beginning resuscitation. So not to be used by itself to diagnose birth asphyxia or predict an individual child's neurologic outcome, since prematurity, maternal medications, congenital conditions, and resuscitative interventions can all affect the score. All right, so the Ballard examination estimates gestational age by asking how physically and neurologically mature the newborn appears. So it is especially useful when prenatal dating is absent, uncertain, or inconsistent with the infant's appearance. Neuromuscular maturity is assessed through resting posture, joint flexibility, recoil, and resistance to extension. As gestation advances, flexor tone generally increases, so a more mature infant holds the extremities in greater flexion and resists passive movement more strongly. Physical maturity is estimated from features that change predictably during gestation, including skin texture, plantar creases, breast tissue, ear cartilage, and genital development. Each finding is assigned a value. The neuromuscular and physical scores are combined, and the total is converted into an estimated gestational age. This estimate matters because the risk of respiratory disease, hypoglycemia, temperature instability, feeding difficulty, and other neonatal complications depends strongly on gestational maturity. The Ballard score is still an estimate and may be affected by illness, medications, neuromuscular abnormalities, and the timing of the examination. Newborns feed frequently because their stomach capacity is small and their energy demands are high, so breastfed newborns commonly feed 8 to 12 times per day in response to hunger cues. Colostrum is produced first and provides concentrated nutrition and immune protection in a small volume. Milk volume then increases over the next several days. Formula-fed infants also begin with small volumes that increase as feeding tolerance and stomach capacity improve. Some early weight loss is expected because newborns excrete excess extracellular fluid while intake is still increasing. Most regain their birth weight within approximately 7 to 14 days. Loss approaching or exceeding 10 pounds requires careful evaluation of feeding, milk transfer, hydration, and possible illness. Output provides a practical measure of intake. Wet diapers increase during the first several days, reaching roughly 6 or more per day by day 4 or 5. Meconium should pass during the first day and the transition to lighter stool. Failure to void or pass meconium on time may suggest obstruction, renal disease, Hirschsprung disease, cystic fibrosis, or another underlying problem. Neonatal jaundice develops when bilirubin production exceeds the newborn's liver's ability to conjugate and eliminate it. Newborns have high red cell mass and shortened red cell lifespan, while hepatic conjugation pathways are still immature. Physiologic jaundice therefore appears after the first 24 hours, commonly peaks during the next several days, and then improves as feeding and hepatic clearance increases. Jaundice present during the first 24 hours is pathologic until proven otherwise. Important causes include immune-mediated hemolysis from ABO or Rh incompatibility, G6PD deficiency, other hemolytic disorders, infection, bruising, and cephalohematoma. And then inadequate intake during the first week can increase enterohepatic bilirubin circulation, while breast milk jaundice is a later and usually benign process in an otherwise thriving infant. Evaluation begins with an objective transcutaneous or serum bilirubin measurement rather than a visual inspection alone. The value must be interpreted using the infant's age in hours, gestational age, and neurotoxicity risk factors. The treatment for this would be phototherapy. So this was actually discovered by nurses. Heard this from my professor, pretty cool. They saw a bunch of babies that were by a bunch of windows actually had improved with their jaundice, while babies that were not did not. So, but it's pretty amazing. So you would first give it the phototherapy, and I think he said that the exact number was about 30%. They need to decrease their bilirubin numbers by about 30% before they're healthy, and that usually takes about 6 hours. I don't know. Pretty cool. But yeah, so neonatal jaundice, there you go. All right, so routine newborn preventative care addresses problems that may not be apparent on examination. So intramuscular vitamin K prevents potential catastrophic bleeding because newborn stores are low and the intestinal microbiome has not yet begun producing adequate vitamin K. Antibiotic eye ointments help prevent gonococcal ophthalmia. And hepatitis B vaccination begins protection early in life. Newborn screening also includes a state metabolic blood panel, hearing assessment, bilirubin measurement, and pulse oximetry screening for critical congenital heart disease. Discharge readiness involves more than stable vital signs, so the infant must demonstrate adequate feeding, appropriate elimination, acceptable weight change, and safe plan for follow-up. Caregivers need clear instructions about safe sleep, rear-facing car seat, keeping the umbilical stump clean and dry, and monitoring jaundice and hydration. They should seek urgent care for fever, respiratory difficulty, cyanosis, marked lethargy, poor feeding, decreased urine output, or rapidly worsening jaundice. Early follow-up, reassess weight, feeding effectiveness, hydration, bilirubin risk, and the family's ability to care for the newborn safely. So newborn circumcision is an elective procedure with potential benefits and risks, so counseling should support an informed family decision rather than present it as mandatory. Reported benefits include a lower risk of urinary tract infection during the first year and reduced acquisition or transmission of certain infections later in life. Potential complications include pain, bleeding, infection, injury, and removal of too much or too little tissue, although serious complications are uncommon when the procedure is performed correctly with sterile technique and appropriate analgesia. Circumcision should be delayed when the infant is medically unstable, significantly premature, or at an increased risk of bleeding. It should not be performed while a penile abnormality such as hypospadis is significant, or significant chordae or ambiguous autonomy is present. So in hypospadias, the urethral opening is located abnormally on the ventral penis, and the foreskin may be needed later for surgical reconstruction. The key clinical action is therefore to recognize abnormal autonomy before the procedure and obtain pediatric urologic evaluation rather than removing potentially useful tissue. Infantile colic describes recurrent prolonged crying in an otherwise healthy and normally growing infant. The classic rule of threes is crying for more than 3 hours per day on more than 3 days per week for more than 3 weeks. Modern clinical definitions are less rigid, but the central idea remains that the crying is excessive, difficult to soothe, and not explained by another illness. It commonly begins during the first few weeks, peaks near 6 weeks, occurs most often in the evenings, and resolves about 3 to 4 months. So colic is a diagnosis of exclusion. So fever, bilious vomiting, abdominal distension, bloody stool, poor feeding, lethargy, abnormal neurological findings, injury, or poor weight gain should prompt evaluation for another cause. Once the infant is shown to be healthy, management focuses on reassurance and caregiver support. Swaddling before the infant begins rolling, gentle rocking, low volume white noise, and other calming routines may help. If frustration becomes overwhelming, the caregiver should place the infant supine in the safe crib and step away briefly. An infant should never be shaken, okay? Right? You just put it down, walk away. All right, so scalp swelling after delivery can often be distinguished by its relationship to the cranial sutures. Caput is superficial edema caused by pressure on the presenting scalp during labor. Because it lies above the periosteum, it can cross suture lines. It is usually visible immediately after birth and resolves within several days. A cephalohematoma is blood trapped beneath the periosteum. Since the periosteum is attached at the sutures, the collection remains confined to one cranial bone and cannot cross a suture line. It may become more noticeable several hours after birth and can take weeks to resolve. Breakdown of the collected blood increases bilirubin production, so the infant's requiring monitoring for jaundice. Don't confuse either finding with subgaleal hemorrhage, a potentially life-threatening collection that crosses sutures and may cause diffuse expanding, swelling, pallor, tachycardia, and shock. Fontanelles provide another clinical window. A normal fontanelle is soft and relatively flat. A sunken fontanelle may support dehydration, while persistent bulging in a calm, upright infant raises concern for increased intracranial pressure. The newborn HEENT examination separates common benign findings from abnormalities requiring prompt evaluation. The red reflex should be visible and approximately symmetric in both eyes. A white reflex, dark defect, absent reflex, or clear asymmetry may indicate cataract, glaucoma, retinal disease, or retinoblastoma and requires ophthalmologic referral. In young children, the auricle is pulled gently down, and during otoscopy, because the ear canal has a different orientation than in adults. So their shorter and more horizontal Eustachian tubes allow nasopharyngeal secretions to reach the middle ear more easily, and so that's why kids commonly get otitis media. Small white Epstein pearls, horrible name, on the hard palate are benign keratin-filled cysts that disappear spontaneously. In contrast, thrush produces adherent white plaques that do not wipe away easily. And then ankyloglossia becomes clinically important when restricted tongue movement interferes with feeding or later function, rather than simply because a short frenulum is visible. The palate should be inspected and palpated for a cleft. Greasy scale on the scalp or eyebrows is typical of a cradle cap, and is usually managed conservatively. All right, so periodic breathing is a normal consequence of immature respiratory control in young infants. The infant pauses briefly, then takes several faster breaths. Without sustained cyanosis, bradycardia, oxygen desaturation, or distress. Apnea is more concerning and is generally defined as a pause of at least 20 seconds or shorter pause accompanied by bradycardia, color change, desaturation, or altered tone. The infant's overall appearance and associated physiologic change matters more than timing alone. So primitive reflexes provide a quick assessment of neurologic integrity and maturation. Rooting helps with the newborn to locate the nibble, while suckling supports feeding. The Moreau response should be symmetric, and palmar grasps should occur in both hands. These early reflexes gradually disappear as cortical control develops, generally during the first 4 to 6 months. The parachute response is different. It appears later, around 6 months, and persists as a protective reflex. A reflex that is absent, clearly asymmetric, or present well beyond its expected age may suggest peripheral nerve injury, musculoskeletal injury, or central neurological dysfunction. All right, so the Barlow and Ortolani maneuvers evaluate different forms of hip instability associated with developmental dysplasia. The Barlow maneuver begins with the femoral head located within the acetabulum and asks whether gentle adduction and posterior pressure can displace it. A positive result, therefore, identifies a hip that is currently reduced but unstable. The Ortolani maneuver begins with a dislocated or subluxed hip and uses gentle abduction with anterior lifting to guide the femoral head back into the acetabulum. Barlow dislocates an unstable hip, while Ortolani reduces a dislocated hip. A true positive finding is a palpable clunk as the femoral head moves across the acetabular rim, not a harmless soft tissue click. These maneuvers lose sensitivity around three months because a chronically dislocated hip becomes more fixed. Limited or asymmetric abduction and unequal knee height become more useful findings. Breech presentation, family history, and abnormal examination increase risk. Ultrasound is used selectively in younger infants, while radiographs become more useful after femoral head ossification begins. Many pediatric skin findings are benign, but location, evolution, and associated symptoms determine whether intervention is needed. Cradle cap produces greasy scale on the scalp and eyebrows and usually resolves with gentle cleansing. Congenital dermal melanocytosis causes flat blue-gray pigmentation, commonly over the sacrum. Documenting its appearance and location helps prevent later confusion with bruising. Atopic dermatitis is pruritic and associated with dry, inflamed skin, whereas congenital nevi should be monitored for changes. Infantile hemangiomas appear often during the first weeks of life, proliferate rapidly during early infancy and later in involute. So lesions threatening the airway, eye, lip, feeding, and other functions, as well as large segmental or ulcerated lesions, need early specialist evaluation because the treatment window is quite brief. Impetigo typically produces a superficial honey-colored crust from Staphylococcus aureus or Group A strep, and limited disease can often be treated topically, while extensive disease requires systemic therapy. Tinea corporis is a dermatophyte infection with a scaly advancing border and relative central clearing. Localized disease is generally treated with a topical antifungal. Confidentiality is central to adolescent care because patients disclose sensitive information more reliably when given routine time alone with clinician. The structure should be explained while the caregiver is still present, so private time feels like a standard practice rather than a response to suspicion. Confidentiality has limits, so immediate risk of self-harm, danger to others, abuse, and certain legal reportable conditions may require disclosure to a protective action. So exact consent and confidentiality rules vary by jurisdiction. Psychosocial interview begins with safer topics and gradually moves towards more personal ones. Expanded version of HEADS explores home life, education and employment, eating, activities, substance use, sexuality, mood, and suicide risk, as well as personal safety. Questions should be direct but neutral and should not assume sexual activity, gender identity, orientation, substance use, or family structure. Strengths and protective relationships should be explored alongside risks. Modesty must be respected during the examination, and sensitive breast or genitourinary examinations should follow institutional chaperone policies with clear patient communication and consent. Tanner staging describes physical sexual maturation from stage 1, which is prepubertal, through stage 5, which represents adult physical development. It evaluates breast and genital development separately from pubic hair because gonadarchy and adrenarchy are related but distinct processes. Tanner stage does not measure emotional maturity, judgment, or readiness for sexual activity. In girls, the first sign of true puberty is usually breast budding. Pubic hair often follows the peak height. Velocity occurs relatively early, and menarche typically occurs 2 to 3 years after breast development begins, commonly around Tanner breast stage 4. In boys, the earliest reliable sign is testicular enlargement, followed by pubic hair and penile growth. Their peak growth spurt occurs later in puberty than it does in girls. Chronologic ages vary, so sequence and tempo are often more informative than a single age. Pubertal development begins before age 8 in girls or 9 in boys, suggests precocious puberty. So absence of breast development by 13, testicular enlargement by 14, or menarche by 15 warrants evaluation for delayed puberty. Adolescence is a gradual developmental transition, and the age ranges on the slide are approximations rather than rigid categories. Early adolescence is dominated by pubertal change and concern about whether one's body is normal. Thinking is often concrete and focused on immediate consequences, while peer influence begins to increase. Patients at this stage benefit from clear explanations and specific examples rather than abstract warnings. During middle adolescence, abstract thinking and identity exploration expand, but impulse control and long-term risk assessment remain under development. Peer relationships become especially influential, and experimentation, dating, and limit testing may increase. Clinical conversations should connect choices to consequences that feel immediate and personally relevant. By late adolescence, identity, values, and relationships are often becoming more stable. Future planning and independent decision-making improve, although development continues into young adulthood. And these patterns help clinicians tailor communication, but they should never be used as stereotypes. Family environment, culture, neurodevelopment, health, and lived experience can shift the timing considerably. All right, guys, that will wrap it up for Foundations 2, Week 1 and Week 2 bars. But thank you guys all. If you are a returning MooseMed watcher, thank you. If you're just now joining us, welcome to the Moose Pack. Merch dropping soon. Just kidding. I should, though. But seriously, it's good to be back. Thank you, as always, for stopping by MooseMed, where we take medicine by the horns, but for all intensive purposes, moose have antlers. Thank you guys as always. Have a good rest of your day.